All right, good morning, everyone.
Good morning. Thank you.
Good morning.
Where's the other?
Morning. Welcome, everyone, to the 5th annual cost trends hearings hosted by the state's Health Policy Commission. We're so pleased that so many of you have joined us here today and tomorrow to engage in a critical conversation about the future of our healthcare system in Massachusetts and to help identify policy solutions that will lead to a more affordable and effective healthcare system. Before we get started with today's hearings, I feel like it's only appropriate to pause and reflect on the tragic news coming out of Las Vegas this morning. Like many of you, I woke up this morning and was shocked and saddened by what had occurred. I think I speak for everyone when I say our thoughts and prayers go out to the victims and their families and everyone impacted last night, as well as those impacted by Hurricanes Harvey, Irma, and Maria. A few logistical things to run through for those in the room. The hearing is being live streamed on the HPC's website and will be posted for all time and posterity on that site. If you haven't already, please take a program book from an HPC staffer at the welcome desk. This program book is good for 2 days, so don't please feel like you have to take another one tomorrow. We're all about cost containment here at the HPC. And I know this is all that you care about, but just so you know, the Wi-Fi information is located on the back of those program books. We sincerely welcome testimony from the public at these hearings. If you would like to provide testimony, please register at the welcome table, and we'll be doing public testimony today starting at 3 p.m. We also encourage you to engage in our online conversation about the hearings using the hashtag CTH17. This year, the hearing is going to focus on looking back to review the state's performance in reducing healthcare spending growth over the past 5 years, and we'll look forward to identify policy options for a more affordable system on behalf of the consumers and businesses which ultimately bear the high cost of healthcare in Massachusetts. To kick off today's hearings, I would now like to turn it over to the esteemed chair, the only chair of the Health Policy Commission, Dr. Stuart Altman. Thank you very much.
Thank you, David. And again, let me offer my best wishes, and the unfortunate situations that David articulated casts more than a little shadow on us. But nevertheless, what we're all about today and tomorrow is very important. It's part of the legislation that created this commission, as well as the overview of our benchmark and activity. And as David pointed out, we take these hearings very seriously because, our role really at the heart of it is to try to figure out how to make our healthcare system more efficient, more effective, higher quality. If we do that, we will lower the spending rate and do it in a way that really improves our healthcare system. And that's what we're all about. So to get us going, I have the privilege of introducing our governor, and I think it's fair to say I don't need to introduce the governor, but I will, but shortly, as quickly as I can, but I don't want to lose sight of the fact that you've been so gracious with your time to come and appear before us since you have become governor, so in 2015. And I'm sure in most other cases, the staffs would be running around writing your testimony and explaining to you all about the healthcare system, but not this governor. I think it's the other way around, as he explains to all of us what's going on. He's had the benefit of working in government in the Weld administration and having had very senior positions in various activities in the healthcare world. So, we're very fortunate to have on our commission one of your most able cabinet secretaries, Mary Lou Sutters, who I'm sure is occasionally talked to you about our healthcare system. So I just hope you get a chance, maybe in your comments. If not, I'll ask you a question. I know you recently were in Washington and spoke before the Congress about how we can put together a healthcare financing system that really does the right thing. And also the amount of effort you've been putting in with respect to drug addiction and the opioid crisis. So I don't want to take any more time. I know you have a busy day. I really appreciate your coming. Governor Baker, thank you so much for coming.
Thank you very much, Mr. Chairman. I'm going to move over because I
Yeah,
can't see
so I
you.
can see you better. I appreciate that.
There you are. So, first of all, thanks very much for giving me this chance to chat with you for a minute or two this morning. You do have two terrific folks from our cabinet serving here, Mary Lou Sutters and A&F Secretary Mike Heffernan. They can certainly do as good a job representing what we're up to as anybody. Thanks for coming, Ray. It's good to see you.
Nice to see you, Governor.
You barely made it in under the wire there, pal. So let me try and start with a few good news notions, and then I'll talk about some of the not so good news. You mentioned, Stuart, the federal reform efforts. Part of the good news is that those efforts, thanks to the hard work of a lot of people, didn't materialize. And I say that with some chagrin because one of the things we did shortly after we took office was we wrote about a 9-page, very nerdy and wonky letter, thank you, Mary Lou, to the feds about all the things we thought they could do to fix and deal with some of the issues and problems with the Affordable Care Act, many of which I know, because I've talked to both Democrats and Republicans, would have bipartisan interest in doing something about. I'm still waiting for the bipartisan conversation on healthcare generally in Washington, and I hope that one of the fruits of the current conversation turns out to be something like that. I can say that I testified along with 4 other governors. It was 3 Republicans and 2 Democrats during a series of hearings that took place over the course of 4 days in front of the Health, Education, Labor, and Pension Committee in the Senate. It was put together on a bipartisan basis by the chairman, Senator Alexander, and the ranking minority member, Senator Murray. And frankly, if you sat and watched those hearings take place over several days, you wouldn't know which one was a Democrat and which one was a Republican, either on the committee or at the table testifying. And it was on a really important issue with immediate concern, which is the next step with respect to the exchange-based products, which typically cover people who are either buying coverage individually, buying it through small groups, or make too much to qualify for Medicaid, but not in their states that they live in, but not enough to access what I would call a fully baked commercial product. And the shame of what's happened so far is that dialogue and that conversation, which I thought was incredibly productive and informed, has been pushed aside, as have many efforts of that kind over the course of the past 6 to 8 months, by a far more partisan conversation that would have required a significant rush to judgment involving trillions of dollars and the health care of millions of people. My hope, of course, is that the conversation will come back to the dialogue and the discussion that along the lines of the one that was being promoted by Senators Alexander and Murray, and I hope that that's where those folks go. I guess we'll just have to wait and see if that turns out to be the case. With respect to Massachusetts, the good news, of course, is we continue to have very high coverage rates. We were way ahead of the rest of the country on that, working on a bipartisan basis, and we continue to be a leader by almost any measure with respect to that. The connector, which let's just say had some issues a few years ago, has been running at what I would describe as a very positive clip. Covers currently about 275,000 people, the highest number of people that it's covered since the Affordable Care Act was enacted and implemented, and with a ton of work, has gotten to the point where most of the intersections that exist between MassHealth and the connector have been dealt with, and where most people come out of their experience with the connector feeling pretty good about it. When we took office, I think the average waiting time was almost an hour, and the abandonment rate was about 50%. The most recent data has an average waiting time of about, these are on calls, an average waiting time in the customer service center of about 35 to 40 seconds and an abandonment rate of 1 or 2%. It's very different, which is good. On the program integrity side, the folks at Medicaid and MassHealth and the folks at the connector have done a good job of installing a whole series of program integrity initiatives to make sure people end up in the right place for the right reasons, but that's just an area where there's always more work to be done, and we'll continue to do it. With respect to the overall trend, I mean, I don't have to tell any of you, since you published the data on it, that our overall cost trend is below for 16 was below the benchmark, about 2.8% on a benchmark of 3.6, which was not only below last year's benchmark, but significantly below the run rate of the previous 2 years. Also good news, pharma spending, which remains the biggest driver of the cost trend, was down significantly, about half of the growth rate of the previous year. I do think some of that was driven by, and I'm sure, again, most of the people in this room know this, most of that was driven by the implementation of a series of blockbuster drugs, the biggest of which was probably Sovaldi, which was a cure for Hep C. And the big challenge I think we all face, and maybe this is a homework assignment for some of you and maybe for us, is to try to figure out how to price the benefit of a drug that cures a condition that has very significant long-term chronic care cost consequences. I'm not sure I know how to do that. I'm not sure anybody's figured out how to do that. But the ability of Sovaldi and all of the drugs that have currently come out since then from Merck and AbbVie and everybody else raises a very important question for all of us, which is, if somebody can legitimately cure something that involves a condition that somebody would have to deal with for the rest of their life, and for which both the human cost and the financial costs would be significant over many, many years, in fact, decades. That's a question worth pondering and trying to figure out how to factor into the way we think about costs generally. The other good news on the pharmacy piece is what's happened in the generic market over the course of the past 18 months or so. I spoke here, I think in 2015, and raised a series of concerns that I had about the lack of competition in the generic marketplace for a whole bunch of reasons. That's changed. It's changed for a number of reasons. Part of it is the buying groups in the generic marketplace have gotten bigger and bigger. Express Scripts and some of the other players have literally collaborated with other parts of the distribution channel to create very big purchasing collaboratives, and those purchasing collaboratives have been able to drive down the cost of generics to the point where I think the growth rate, according to one study I saw in 2016 for generic drugs overall, was minus 2.4%, which in healthcare and for drugs in particular is astonishing. The part of it that is complicated and that we all need to think about is, wasn't that long ago when generics represented about 70% of the drugs that were prescribed and about 50% of the cost, and brand name drugs represented about 30% of the drugs that were prescribed and about 50% of the cost. For the data for 2016, because of the drive down on generic pricing and the increase driven by some of the blockbuster drugs that are out there, we now have a situation where generics represent about 90% of the prescribing and about 25% of the cost, and brand name drugs represent 10% of the prescribing and about 75% of the cost. That's an issue I think we all need to think about how to deal with going forward. With respect to MassHealth in particular, one of the things that was in the survey data that I read that you folks had developed was that people were concerned about people had a desire to continue to change sort of the way the payment systems work, to make the payment systems more value-oriented and more team-based. I'm pleased to say that with a ton of hard work by the folks at Health and Human Services and the folks at Mass Health. We've been able as a Commonwealth to launch a pretty dramatic and pretty significant change in the way the payment models work and move to an ACO-type payment model. Almost every large system in Massachusetts signed up based on a network that they had developed in conjunction with their colleagues. And these networks aren't just big hospital networks. One of the biggest networks was a community health center network. And I do believe that as one of these people who thinks in the long run, and in the short run, one of the most important things people need to do is to figure out how to practice in a team-based way, because we are in a situation where, 5% of the population represents 50% of the spending, and that 5%, generally speaking, usually has multiple conditions they're trying to manage, are seeing multiple clinicians because of those multiple conditions. And the more we can do to encourage providers to engage in a team-based approach to care delivery, especially now that for the most part, everybody's got some sort of electronic health record in place so that data is relatively available with respect to what's going on with a particular patient from one place to the next, the better off we're going to be. And that's a major lift, and it was tied specifically to one of the primary criticisms we received from the federal government with respect to the way we were running our healthcare system on the Mass Health side. Previously, it was the source of a major piece of the negotiation that we had with the Obama administration around the reauthorization of our 1115 waiver, which was signed in the fall of 2016. And I think it sets the table in a very positive way for us going forward. It also includes a significant investment in both addiction and behavioral health services, which brings me to the other point you brought up, Mr. Chairman, which was addiction and opioids. I'll leave it to others to talk about the financial cost of the opioid epidemic. I'm going to focus a little bit instead on what I would call sort of the human cost. For 15 years in Massachusetts, the number of prescriptions that were written, the number of overdoses that were incurred, and the number of deaths in the Commonwealth went up every single year. And in some cases, most cases, by double digits, and in many years by 30 or 40%, to the point where it finally became the public calamity that it should be labeled as. I continue to run into many people who, despite a lot of work by a lot of people, I continue to run into a lot of folks who are uncomfortable discussing their own or their family members' battle with addiction of one sort or another, whether it's opioids or something else. And while we continue to invest in paid and public service advertising to promote the notion that there should not be a stigma associated with battling this disease, it continues to be an issue for many individuals and many families. I do think many of the elements of the legislation that we enacted in conjunction with our colleagues in the legislature are bearing significant and positive fruit, but we have a ton of work left to do. But that said, the redesign of the prescription monitoring program, which made it much simpler to use, dramatically amped up the number of prescribers who actively use it and the number of folks who are in there using that data and looking at it. I think we had twice as many inquiries in the first 6 months as we'd had in the last 6 months of the previous system. Mary Lou will tell you if I'm wrong on any of this.
I wouldn't think of it.
Yeah, right. And the other thing I would say about that is it clearly had an impact on prescribing generally. If you look at prescribing overall, the number of prescriptions being written in Massachusetts has dropped by a pretty significant margin. And while we still have issues with overdoses, the presence of Narcan, the distribution of Narcan, and some of the success we've had on prescribing has meant that for the first 6 months of this calendar year, for the first time in 15 years, the total number of deaths went down. It's still way too high, but after 15 years of nothing but negative trends, all going in the wrong direction, to see some positive developments there. Our goal is to try and take what looks like an aberration at this point and turn it into a trend that continues to move it in the proper direction going forward. I also believe that some of the elements of the training protocols that we've put in place for anybody who graduates from nursing school, medical school, dental school, or pharmacy school, as well as the requirements that if you're a prescriber, when you get relicensed, you have to take and pass a course in opioid therapy and pain management, has been helpful. We've also, for the first time, put people who are addiction specialists on our boards of registration that deal with medicine and nursing and pharmacy. And the final piece I would mention is we've increased our spending on the state side by about 50%, and that doesn't count what's going on the Mass Health side. That's literally just the stuff that's on the appropriation side, and dramatically expanded our treatment capacity, and have tried to be geographically smart about it. In other words, a lot of the new capacity is located in places where there simply wasn't any previously, which makes a big difference for folks in those communities. We still have a lot to do on this, and the Secretary and I and others have been working on what I would call sort of a second act on this, and we'll have more to say about it later this fall. The bad news on that particular issue is it's still an enormous problem. It's an enormous public health problem, but it's just an enormous human cost problem more than anything else. And we continue to make progress, but we have a really, really long way to go to get to where we should be. And you know, I was down in Washington as part of this commission I'm on this issue last week, and we had a panel with mostly folks who are from the pharma community to talk about non-addictive pain medication technology. But there was a guy there who was formerly a surgeon in Britain. He's now working with a pharma company in the U.S. And since I had a guy there from Britain, who was a surgeon, I looked at him and I said, "So tell me about how you guys handle pain and surgery in Britain." And so he walked through the process, and it's basically a tiered process that starts with, he said, if you come in and it's traumatic, it's an automobile accident, or you fell out of a window or something like that, he said, all bets are off, and we just go as hard as we can with whatever we think makes sense in terms of managing pain. But he said, for most of the rest of it, we're very focused on not overusing opioids, and we typically use other alternatives unless we absolutely positively believe somebody needs opioids, and we would never write a prescription for somebody leaving the hospital for more than 7 days worth of medication. So that's our upper limit, 7 days. I then turned to some of the folks who were there from the National Institute of Health and said, what about that? I really think the U.S. is 5% of the world's population. We consume 80% of the world's opioids. There's simply no question that a big part of this problem has to do with the casual approach we've taken to prescribing these medications. And anybody who wants to get what I think is the best tale told with respect to how we got here, there's a book called Dreamland that was written by a Los Angeles Times reporter named Sam Quinones, which lays out, I think, in pretty clear and stark terms that our desire for, our hunt for, our belief that there could be a non-addictive pain medication led a lot of people down a path that we will all be sort of trying to dig ourselves out of for a very long period of time. Some of the other things I think are still challenging. One is we still lack what I would describe as useful and timely and accurate cost and quality data that's available to the public generally and to the provider community in particular. I know you folks, Ray, are working on something. I look forward to seeing it. Tomorrow would be great. But I do believe that if you really want to have an aggressive and informed public conversation on this issue, you got to have publicly available data to discuss and engage and debate in. And I do think that would have a positive impact on the way people think about almost everything associated with network construction and where they get their care and why they go there and all the rest. I also think we still have issues that we need to wrestle with on the role that Mass Health plays with respect to the state's budget. Over the past year or two, the team has done a pretty good job of limiting the rate of growth in the per member costs. But one of the big challenges we have faced has been the run-up in the number of people who are enrolled. And I think the work that's being done on the program integrity side to deal with that is effective. But I also believe that there are simply limits to how many years in a row you can go with just saying to the provider community, you're not going to get any increases. And I think part of our challenge is to find the balance between those two elements. We put a whole series of reforms in front of the legislature, which they said appropriately that they wanted time to digest and discuss and think about. And our hope is that sometime this fall, we'll be engaging with them in a pretty robust conversation about some other things we can do to deal with the role and the size and the cost of the Mass Health Program in terms of our cost of government generally. And then the final thing I just want to mention is there's still several really big federal issues hanging out there. The CHIP program, which has been really important to Massachusetts, and we were one of the first states to sort of adopt it and chase it hard, has not been reauthorized. I think it was due to be reauthorized by September 30. Am I right about that? Yep. Yeah. And that worries me. And they also did not reauthorize the Community Health Center program. So while their lack of action on some of the issues around ACA reform may have been good news, there's a whole bunch of other things where lack of action creates real issues for everybody and in a very immediate term. The CSR lack of action is a big issue in the short term. The CHIP program is a big issue in the short term. The community health center stuff is a big issue in the short term. And they all raise questions about the viability of both the 1115 waiver we already have and some of the issues we've raised in the 1332 waiver that's currently pending before the feds. And with that, I'll stop and tell you again that I appreciate the chance to be here. I look forward to the commentary that comes from the rest of the hearings and continuing to work with you all. Thank you.
I know you have to run, but maybe if there's one or two questions that my colleagues might. Well, I just want to say thank you for all of us on the work you've done and your administration in terms of helping to make our system as good as it can get. It's been a privilege to work with you. Thank you so much. Thank you.
Okay, folks, thank you.
Is he here? Okay. Is our president of the Senate here? All right. Oh, sorry.
The little guy in the front row.
You know I have special feeling for little guys, so. So recently, last week actually, I had the privilege of going to the great state of Delaware because Delaware is dealing with some of this, you might find this hard to believe, but Delaware is dealing with some of the same problems we're dealing with here in Massachusetts. Actually, its rate of growth in terms of healthcare spending is far exceeding ours, and they've crept up to be right next to us in terms of the third most expensive state in the United States. So they're trying to understand what we've been doing, and they're very intrigued by the laws that we put in place. And one of the state senators came to me and he said, what I don't understand, but I wish you would explain to me, is how you've been able to get your state Senate and House and your providers to work together to do what you've been able to do. And I said, it has a lot to do with leadership. It has to do with leadership at the legislature. It has to do with leadership in our delivery system and in our payment system, but particularly in our legislature. So if you wouldn't mind coming up, I would like to introduce our president, Stanley Rosenberg, who has been so appreciative. We've been so appreciative of your spending time and willingness to come and join with us. probably no more important than this year, because I understand some little birds have been coming or tweeting around telling me that you and your colleagues in the Senate have been really working hard to sort of take a hard look at our healthcare delivery system and really try to put together the next stage of legislative changes to make it work even better. And I don't know whether you're willing to share a little of that activity with us, but I want to thank you for coming. It's been a pleasure to work for you and your staff, and it's a personal pleasure, the ability to sort of work with you. So thank you. I'd like to introduce to everyone our Senate President, Stanley Rosenberg. Thank you so much.
Well, thank you, Mr. Chairman. Thank you very much for holding these hearings each year and for providing an opportunity for the Senate to be present and to reflect on some of the work that the Senate's doing. You may remember that last year when I sat here, I told you that we were about to launch on a major research project to try to identify some cost centers here in Massachusetts that could use some attention. And so today I will report on the last year's worth of work, and to let you know that within a matter of weeks, we will release a package based upon this research and this work. And so I'll give you the chronology and the detail that's necessary. But first, let me just say that the context for us is a situation in which Mass Health in particular, which is of great concern to the government because we have a very, very robust public insurance program in Mass Health, is projected to grow in this year by 6.4%, and our revenues are projected to grow at 1.4%. So spending on Mass Health, which is a very important public investment, is crowding out spending and public investments in many other important areas of the budget. And so there is an extraordinary tension between our desire to ensure that people have health coverage and high-quality access and high-quality health care. We are really struggling to maintain that and also maintain our other important functions in government. And the other important data point is that high premiums have been consuming more than 40% of the growth in family income over the last 9 years. So it doesn't just affect the government, it also affects businesses and families throughout the Commonwealth. And so a set of reforms has to address both Mass Health and the rest of the system, people who are getting their insurance through non-government programs. So the project that we announced last year that we were launching was going to be done with the cooperation and support of the Milbank Memorial Foundation in New York. They worked with us on a major study the year before on marijuana in anticipation of the potential for the voters to legalize recreational marijuana. We developed such a strong working relationship with them that they approached us and said, "What's next?" And we were very excited to have that question posed. And we then put forward a project which essentially was to identify some key cost centers that Massachusetts was perhaps lagging in, and asking their assistance in helping us to identify other states where best practices were being developed that we needed to learn about and see if they could be adapted for Massachusetts. So we accepted the opportunity that they presented to us very, very enthusiastically. Our first step was to bring together a meeting with the Health and Human Services Secretary and her team, and David and your team, and the Milbank Fund, and we discussed and identified a series of projects or areas that we wanted to research. And those turned out to be integration of behavioral health, long-term services and supports, impacts of social determinants on health and innovative care delivery models, and pharmaceutical drug costs. And you may remember that last year also, my comments after I told you that we were going to do this study was focused on drugs. And we have been working in the Senate for a long time trying to find approaches. Our major effort was focused on the area of aggregation of demand. And we do some of that in state government. We were trying to find models to cross over into or beyond the government, and we were not having very much success, but it still is an area of high need and high demand in terms of cost containment. The next thing that we did was to identify for ourselves what the criteria or let's say at the 50,000 foot level, what were we trying to accomplish? And from our point of view in the Senate, we wanted to maintain access. We thought that was absolutely critical. The Commonwealth had worked more than a decade, probably close to 2 decades, in order to create universal coverage in the state, and we are at virtually at universal coverage, and we did not want to compromise that. The second is we wanted to make sure that we were giving the highest possible quality care through that access and not shift people around and move them to lesser quality or compromise quality in the system in any way. The third was cost containment. If we couldn't reduce the cost, we at least wanted to slow the growth in cost and through efficiencies, not by moving people out of programs or giving them less coverage and service and quality. And then finally, we wanted to improve outcomes. So those were our 4 major criteria. So the group headed up by Senator Jim Welch, our chair of the Healthcare Finance Committee, along with Senate Majority Leader Harriet Chandler, who had previously been a health chair in the House, and Senators Karen Spilka, Jason Lewis, John Keenan, and Patrick O'Connor became the core working group. And for a year, they participated in extensive amount of research, some travel. We traveled to Minnesota and to Vermont, and we had engagement with Oregon, Washington, Texas, and Maryland virtually through teleconferencing and conference calls. And so we brought these specific 4 areas: behavioral health, long-term services and supports, social determinants of health and innovative care delivery models, and pharmaceutical drug costs, to those states and identified what they were undertaking that was producing quality service, access, and improving outcomes while reducing or slowing the growth in costs. And we've been able to identify, with their help, a series of measures that could be undertaken. We didn't ignore our own people, because this August we did a series of roundtables. I think there were 4 in total, and we invited certain people to the table, trying to make the groups at the table as representative and broad-based stakeholders groups as possible for each of those 4 meetings. And they were very well observed by really scores and scores of other people who sat in the room and observed the discussion and gave us additional feedback through email and meetings and other forms of communication, because there wasn't room at the table for everyone, but there's room for everybody's opinions in the conversation. And believe me, we heard from a lot of other people, as it should be. So we now are at the point where we are drafting legislation, and within a matter of weeks, we will be releasing that legislation. And as part of that exercise, we are considering 2 other things. First, the Price Variation Commission recommendations. About a year's worth or 6 to 12 months worth of work was put into that. There was some strong agreement on some of the recommendations. There was consensus on some. There was a majority on others of the recommendations, and there was an uneasy alliance around the remainder. And we're certainly aware of the the challenges involved in that discussion. And then the governor, during the budget process, made a good faith effort to put some proposals on the table that related to Mass Health. And we promised the governor that although we couldn't take it up in the conference committee because they came too late, we promised him that we would give it a fair and detailed study, and we have done that. And so the governor's recommendations are in the mix, and I predict that some of what he has recommended in that package will be in the package that we release, but not all of it. And there will be some elements from the Price Variation Commission in the package, but not all of it. And then we will go beyond that to elements that we have been able to develop as a result of the work that we've done through the Milbank Foundation. And I will just, without going into detail, I'll tell you that among the goals that will be reflected in that legislation are to reduce hospital readmissions, reduce unnecessary emergency department use, provide greater transparency to prescription drug costs, and encouraging savings through increased collaboration, thereby reducing prescription drug costs. And this work was done collaboratively. It was not an inside job. It was done collaboratively with the pharmaceutical community and others, and we're very excited about that package. Improving access to behavioral health and commercial market reforms designed to protect consumers and support high-value healthcare providers. And again, there will be reforms related to Mass Health based in part on the governor's proposals. So with that, we hope that we will have a bill out of the Senate by the end of November as we break for the holidays. We believe that there are plenty of other ideas out there. No one group can possibly vet and come up with every idea that will contribute to helping us control and help control healthcare costs, improve outcomes, maintaining access and quality. And so we look forward to hearing proposals from our colleagues in the House, additional proposals perhaps from the administration, and hopefully from this fine group as well. And I want to thank you for the cooperation and assistance you have provided us. Your chair participated in a roundtable earlier in the year with a group of folks at my request, and I thank you very much for having done that. And it was that conversation that actually led to the creation of the project that we brought to the Milbank Foundation. So you were very much a part of it by being part of that conversation. So again, I thank you for the time this morning and the opportunity to give you an update on what the Senate's trying to do. And again, I underscore we want to do our part, but we know that this requires everyone to be at the table.
Well, again, thank you. We really do look forward to seeing the benefits of that discussion. And I'm sure, I speak for David and one of my fellow commissioners that we will continue to work very closely with you and your staff on making this work. Again, I'd like to thank you for your leadership and for all the things you've done. And I'm sure we'll continue to do it. So thank you again for joining us.
Thank
and
you
we
for your
look forward
kind
to working
attention and
together. Thank you.
invitation.
All right, I'm going to turn the program back over to our Executive Director, David Seltz, and we will continue to make this an exciting morning. David?
All right. Thank you, Mr. Chairman, and thank you to the Governor and the Senate President for joining us this morning and for offering your perspectives and, as the Chairman said, for your leadership on these key issues. I also do want to reflect that we are joined here in the audience today and online by many other senators, representatives, a lot of staff here. So please, so glad to see all of you. And really, part of one of our goals in the hearings this year understanding that the legislature is considering some additional steps as informed by the administration and their recommendations as well, that these hearings can be a place to add to that conversation in terms of what some concrete steps may be moving forward. With all things, we like to be data-driven in how we develop our policy recommendations. And so at this time, I'm going to call Ray Campbell and Dr. David Auerbach to join us at the testimony table to provide us with that clear data foundation in terms of both the performance of the Massachusetts healthcare system, but also scanning back out how our performance compares to the United States and to some national trends. Ray Campbell is the Executive Director of the Center for Health Information and Analysis, or CHIA, a sister agency that was established in Chapter 224, and a close working partner of the Health Policy Commission in developing our work. And we rely so heavily on the research and the data collected by his agency and analyzed by his agency. And every year they have advanced their ability to provide real insights into healthcare trends, and so have asked him to present some key findings from their recently released annual report. This report may be found on their website as well as on our website. After Ray, we have Dr. David Auerbach, who is the Director for Research and Cost Trends at the Health Policy Commission. He leads our team of analysts in analyzing the all-payer claims database and other important data sources, and the development of our annual cost trends report. I've asked him to present on trends in context with the national landscape. So with that, I'll turn it over to Ray.
Thank you very much, David. Commissioners, it's a pleasure to be here. I must say, following up on something David said, we are a sister agency of the Health Policy Commission, and so we work very closely throughout the year, but we have a front row seat, if you will, on the preparations that go into these cost trend hearings, and I have to tell you, there's just a huge amount of work that goes on behind the scenes, really, really good work, and it's very seamless. It's like when you watch a professional athlete and you say, well, that looks really simple. I think I might be able to do that. It's the thousands or the 10,000 hours of practice and preparation that went into it, so kudos, David, on a great job for the cost trend hearings. So it's my pleasure to be able to provide a factual foundation for some of the discussions that will follow. I'll go through findings from CHIA's annual report that were recently released, and I'll be focusing in on a couple of major areas. First, 2016 total healthcare expenditure growth, and breaking that out in a few ways. Next, looking at the cost drivers that contributed to healthcare expenditure growth in 2016. Actually, let me click forward. Great. Following that, we'll take a look at the adoption of alternative payment methods and how that progressed. Next, we'll look at the cost of coverage and member cost sharing. And then finally, we'll shift gears a little bit and look at hospital readmission data. That actually wasn't part of our annual report, but it's germane to a number of the presentations and conversations that will be happening today. So we wanted to provide you folks with some of that factual information. So this is kind of the headline slide, if you will. This shows in the upper right-hand corner, you see the 2.8% change in per capita total healthcare expenditures from 2015 to 2016. That is below the benchmark of 3.6%. That represents a total amount of spending of $8,663 per capita in the state, or a total expenditure amount of $59 billion. This is for insured healthcare services, both the costs covered by insurance as well as by member out-of-pocket. This slide breaks down the expenditure growth by insurance category, and so you see that commercial insurance, which is the largest category, grew at 3.4%. Next, Mass Health grew at 4.4%, Medicare at 3.3%, and then there are smaller categories at the top. All of those rates, I believe, are lower than the prior year. Turning to a service category breakdown rather than an insurance breakdown of where the total healthcare expenditure costs were, you see both the total amounts spent in 15 and 16, those are on the outsides, and then the growth rates in the circles in the center. So you can see that hospital inpatient growth was very restrained at 2.2%, but hospital outpatient spending increased at 5.5%, and we'll have a little more to say about that. Physician spending was up 1.7%. Other professional services up 5.4%, pharmacy 6.4%, and then the other category, which includes long-term care and other things like that, 2.7%, and non-claims payments were down 2%. So that's the service category breakout. And this is a different way of looking at it where this is the contribution of the different service categories to the total change in expenditures from 15 to 16. And so you see the largest source of change was from the pharmacy spending, $547 million, and then the second largest contributor was hospital outpatient, and then the other categories below that contributed less. In light of the important role that pharmacy spending plays, CHIA wanted to take a closer look at that, and in response to requests from prior years as to whether CHIA could do a better job of understanding pharmacy rebate spending, we did a deeper dive on that in this year's report, and the results were actually rather interesting. What you see on the left-hand side is pharmacy spending prior to the impact of rebates. And I should mention that in the past, we have accounted for rebates, but not netting it against pharmacy spending. What we would do is it was factored in elsewhere. So we saw the spending, we saw the rebates, but we didn't match them up one against the other. And so what you see in this slide is that on the right, if you actually match the rebates against the pharmacy spending, you see that the increase in spending last year of 12.1%, that was sort of the gross increase, was moderated to a 7.2% increase. So a pretty significant impact on pharmacy spending as a result of the rebates. Then in 2016, the gross number, if you will, the 6.4% moderated to a 6.1% if you attribute the rebates to it. So you see a continued impact of rebates, but not nearly as big as was the case in the prior year. And then this is another interesting look at rebates vary dramatically in a number of dimensions, and CHIA's information about rebates is still at a fairly high aggregate level. And so we can't tell you how it varies by brand or generic or specialty or by particular drugs, but we can look at the different insurance categories and see that, for instance, in the commercial market, about 10.4% of drug spending is returned in the form of rebates, whereas Mass Health, the fee-for-service and the PCC program, it's 52%. And that's being driven a lot by federal laws in this area. But you just see significant variation across different insurance types in terms of the amount of rebates being paid. This slide shows the adoption of alternative payment methods by different insurance types. So on the left-hand group of bars, that's the commercial market, and then the two right-hand clusters are Mass Health. In the commercial space, after a small decline last year, we saw a significant increase in alternative payment methods from 35.7% to 42%. So a significant increase. This was mostly due to actually one insurer, Blue Cross Blue Shield, shifting about 25% of its PPO members into alternative payment methods. So a good performance in the commercial market, significant increase in the adoption of APMs. In the Mass Health market, slight trending, or basically even or treading water in this space, but this is prior to the launch of the major Mass Health push on ACOs, so we would expect these numbers to change a lot in the out years. And then you can see from the colors of the bars, the overwhelming majority of alternative payment methods remain global payments. This is now we're starting to take a look at the cost of coverage, and this is fully insured premiums by employer size. And what you see is there's a sort of a faint bracket on the left. That's all employer-sponsored insurance. And then at the very top row is the individual market. And what you see is that there were increases across all of the groups, the small group, mid-size, large, and jumbo, and at the GIC, but the individual market, there was actual decline in premiums, and that's because of the large shift of people into connector care and products like that with lower premiums. So other than that market where you saw a decrease in premiums, we continued to see premium increases in the other market segments. Okay. This is taking a look at the penetration of high-deductible health plans in Massachusetts and breaking that out also by different market segments. So the orange line that you see in the middle, that's the total market. And so you see that penetration of high-deductible health plans increased to just over 21% in 2016. So more than 1 in 5 members in the state is covered in a high-deductible health plan. And then if you look at the market segments, those are the other lines on this chart, you see that the small and mid-sized markets have very high penetration of high-deductible health plans, 50% of the small market, 44% of the mid-sized market, and in fact, the total number of people in high-deductible health plans in those two market segments is more than the number of people in high-deductible health plans in the jumbo market, even though it's a much larger market. And the individual, you see the decline in high-deductible health plans, once again reflecting the shift of people into connector care where they don't have high-deductible health plans. Continuing to look at cost-sharing issues, this is a breakout of cost-sharing, member cost-sharing, and how it varies across employer size. So you can see a very clear association that the smaller the group, the cost sharing goes up. I guess if you start at the bottom of the chart and work your way up from the jumbos to the large to the mid-size to the small, you see a steadily increasing amount of cost sharing. The right-hand column also shows that these amounts have been increasing at a pretty steady clip other than the jumbo market, where it was only up 2.5%. The one exception to all of this is, once again, the individual market, where you see that there was an actual decrease in cost sharing, and that is reflective of the shifts in the populations into the connected care programs. Okay, so we're going to actually shift now just the last few slides and take a look at revisits and readmissions. As you'd seen from the earlier slides, hospital outpatient was a significant cost driver for this year, and I know there's other testimony and panels that'll be looking at hospital cost issues, so wanted to share the results of some recent CHIA work on hospital revisits and readmissions. What this slide shows you is that we took a careful look at 525,000 discharges. That's not all discharges, but of the 525,000 that we studied, 26% of the discharges resulted in a return visit to the emergency department within 30 days. And this is an interesting statistic, and then 16% resulted in readmissions. This is our first look at revisits. In the past, our statistics really only captured readmissions, and we wanted to take a look at the phenomenon where people would go back to the hospital, which represents a problem of some kind and incurring additional cost and all the other things, but didn't necessarily lead to a readmission. So what you see here is, as I said, of the studied discharges, 26% resulted in a revisit, 16% in a readmission. On the right-hand side, you see the state's performance, the overall performance on readmissions, where after a couple of years of declines over the past 2 years, we've actually trended back upwards. This slide just shows that the readmission rates vary by a number of dimensions, but one of them is the type of individual and the type of insurance they have. You see that Medicare, covering older people, you have a higher rate of 18%. Medicaid, you see a rate of 17%, and then commercial insurance, the readmission rate is 11%. This is an important dimension of the problem that I think we're all aware of, but this is just the most recent data on it. Of the 42% of patients that have a behavioral health comorbidity, their readmission rate was 20.8%, substantially higher than people who did not have a behavioral health comorbidity, where the readmission rate was 11.4%. And the chart on the left shows the breakdown of the behavioral health comorbidities, and the chart on the right shows the readmission rates. And then lastly, in terms of thinking about how to address the problem, it's, you want to find the high leverage populations, and this isn't to suggest that certainly much more work could be done to identify what's driving this, but this is certainly one indicator of what's going on. 7% of patients were defined as frequent hospitalization patients. Those are people that had 4 or more hospitalizations in a 12-month period. Didn't have to be a calendar year, but 4 or more in a 12-month period. Although there were only 7% of the population, they accounted for 25% of the discharges and 58% of readmissions. So you see that the readmission problem seems to be focused very heavily on these frequent utilizers of hospital services. So there's a lot more, I think, that we can learn about these populations by studying them. I think we'll learn more from the panels that we're going to hear from today and tomorrow. And that's my last slide, so I will turn it over to David, or did we, David, I don't know how you wanted to handle questions at the end of the two panels. Yeah,
Why don't we do it to David, and then we'll ask both of you?
great. Thank you.
Okay. Okay, thanks, Ray. And as David Stelz introduced in the beginning, I'm going to be placing some of these numbers in a national context as well as in a time trend within Massachusetts. So stepping back a bit, and at the end, I'm going to talk about affordability of care and what that means for the average American Massachusetts family. Okay. So to start out, let's go back to 2009, the top half of this graph. And this is spending per person in Massachusetts compared to all the other 50 states. And many of us have seen this before. In 2009, we were the highest spending state in the country. We're there on the right by a considerable margin. And of course, the United States is the highest spending country in the world. So I think that partly led to the motivation of Chapter 224. So now zooming ahead 5 years to the end of 2014, you can see that we are no longer the highest cost state in the country. We are overtaken by Alaska, which is fortunate. And we achieved that not just by Alaska zooming up, but as I'll show on this slide, we had the fourth lowest rate of growth of healthcare spending between 09 and 14. You can see us on the left at 2.3% compared to an average of 3% in the rest of the country. I'll show a little more about how we did that. This is showing, instead of that 5-year growth rate, growth year by year going back to 2000. Massachusetts is in the orange on top. You can see our annual growth rate in healthcare spending was above the US average every year until about 09. And then since then, we've had 7 straight years of growth below the US average. This is data from CMS, although in the last 2 years, this is data from CHIA. And you can see the US rate in 2016 is partially projected, but it looks like we're going to come in below again. So that's some good news. Here, same idea, but just in the commercial sector. And we're plotting out back to 2006 our growth rates in the commercial coverage. This includes employer-sponsored coverage and the connector in the individual market. And you can see in the orange, our growth rates were considerably below the US average rate for commercial care. And if you actually add up that difference between the orange and the blue for the last 4 years, we have saved about $5.5 billion in commercial healthcare spending compared to what we would have spent if we had the US rates of growth. Now I want to point out that, as Ray noted, part of that savings is driven by the connector. On the top, you can see employer coverage. This is average single premiums for the year. In Massachusetts in the red and in the US in the blue. And our employer premiums in 2012, they were, you can see about $1,000 above the national average. And that gap has shrunk a bit. But our employer-based premiums are still relatively high, 4th highest in the US. But now go down below that, and you can see our Massachusetts connector premiums. This is the benchmark, second lowest cost silver plan compared to the US and all the exchanges across the country. Those premiums have actually dropped in Massachusetts to the point where by 2017, we're the second lowest premiums in the country. And that trend is so significant that it actually brings down those employer commercial trends that Ray noted by about 1 point each year. So the employer growth trend is about 3%, and the connector growth trend is negative. It's impressive, and I think that Chia is going to spend a little more time on this on a brief coming up soon. So our growth has been low, but now I want to shift to going back to our levels of spending, which are still high. This chart shows on the x-axis median income, each dot is a state in the country, 2014, and our healthcare spending per person on the y-axis. And you can see that line is reflecting that higher income states tend to have higher healthcare spending. But even given that, Massachusetts on the right is above that line. So 4 states with high income, and you can see those states on the right, New Jersey, Maryland, Connecticut, in the high income club, we are still among the highest. Only Alaska and DC are above us. So even accounting for income, we're still a high spending state. And then we can ask, where does our relatively high spending come from? Here, we're breaking it down by category of care. And I'm showing it in the blue in 2009 and in the orange in 2014. You can see that hospital care accounted for the biggest chunk of our excess spending in 2009. By 2014, that's been eclipsed by excess spending in long-term care and home health and post-acute care. That's in the orange. So that has grown, has increased relative to the US. And then the other categories showing where our excess spending is some in the professional services, physician care, and the contribution of drugs has also increased since '09. Okay, now I'm going to shift to some utilization trends over time and compared to the rest of the country. This is showing our trend in inpatient hospitalizations. You can see that we dropped from about 2011 to 14 in our rate of hospitalization per capita in the state, but that has stalled, that decline has stalled, and we remain about 8% higher use of the hospital than other states in the country. Here showing, again, a slide that Ray showed about our readmissions rate. We were declining 11, 12, 13. Massachusetts is on top there. The US rate is in the blue. The rest of the country has continued to go down while we have started to go up. And we're still working on the 2016 data, but this is not a great trend. Our Medicare rate is on top, going back up, and our all-payer rate is on the bottom, going back up. We have a target of 12.2% by 2019, so it's going to take a lot of work to get there. Here is our comparison in ED visits per capita. Massachusetts in the orange again. In this case, we have held steady or even dropped a bit since 2010 while the rest of the country kept growing. So we've made up some ground, but still about 8-9% higher use of the ED than the rest of the country. Here's a bit of good news. Something else we track is the percent of people in the hospital that then go on to a skilled nursing facility or an inpatient rehab, institutional post-acute care. In the last couple of years, we have dropped a bit. And we looked into this a little more closely and found that most of that is because of declining rates in the joint replacement musculoskeletal area. So we're going to look more at that in our cost trends report, but that's a positive trend. But the US rate is still around 15%, so we're considerably above. And finally, before I shift to affordability, something we track is do our community appropriate hospitalizations take place in community hospitals? These are low acuity cases that could be handled at any hospital in the state. And the blue line is showing, well, what percent of those actually did occur at a community hospital? And that has dropped. We'd like that to be going higher as part of our right care, right place, right time mission, and that has not been going in the right direction. We'll hear more about that in panel 2 today. Okay, so what does all this mean? The next 3 slides, I'm going to be using some data from CHIA's health interview survey, and collecting some outcomes and showing what this means for typical families in the state. So what we've done here is analyzed middle income families, those between about 200 and 500% of the poverty level. And here they're divided into 2 groups, those who report they're in better health in the orange on the left, and those who report they're in worse health in the blue. And here's a bunch of outcomes and how these families report. Average out-of-pocket costs, that's per year. You have $3,800 in spending for those in worse health versus $2,400 for those in better health. Those in worse health are having twice as much in terms of visits to the ED per year, and a much higher percent with outstanding medical bills that they are paying off. Then when you ask families, have you had to delay or postpone care because of cost? Those in worse health, far more likely to not fill a prescription because of cost, to not get care from a doctor, and to not get dental care. And again, these are all folks of approximately the same income, showing that those burdens are higher for those in worse health. Okay, now I'm going to combine all those families together back to an average situation for a family of 4 in the state and show what their annual budget would look like in terms of the affordability of healthcare spending. So the average income for families in this group is about $75,000 per year. And now I'm going to add into that other benefits they're receiving from their employer. Because the cost of the employer is higher than that $75,000, they're paying a portion of the premium on behalf of this family and other payroll taxes. So it turns out that the total compensation received by this typical family is about $7,800 a month. So the circle there is depicting where does that income go? Everything in the orange is healthcare. That bigger bar on the top, $1,100 a month, is going to that premium, the employer-paid portion. The next bar, $374 a month, the employee contribution to that premium. Then you have out-of-pocket health spending, $234 a month, the portion of their taxes that go to healthcare programs, Medicare, Medicaid, and another $250, and combined, that is more than $2,000 a month coming out of that family's budget that is paying for healthcare, 25%. Then you have in the dark gray are other taxes paid, and then everything in that light gray is what they have left to spend on housing, food, transportation, everything else. Okay, so that's our baseline story. And in this last slide, we're going to go through a couple of what-if scenarios. So how does that family's budget picture change if things were different? So look on the top graph. That shows the premium trend, and in the orange is the baseline. These are now family premiums per year, and the orange depicts what actually happened with those premiums. And I'm collecting outcomes in 2015. So on that table on the bottom, you can see state health insurance spending was $23.6 billion in that year. The amount of income tax revenue collected by the state, $14.374 billion. The family, let's assume an average raise of 2% per year, and the family has about $54,000 left over after paying for healthcare and taxes to spend on everything else. Okay, scenario one, what if? What if our healthcare spending, instead of being on that orange line, was the dark blue, was the, I think it's actually gray up there, was the spending trend for the rest of the country, which we showed you earlier was actually higher. What if we had spent more? In that case, state health insurance spending would have been $1.4 billion higher in 2015. The state would have collected $349 million less in income tax. That's because as employers spend more on premiums, they spend less on salaries. And those salaries, we collect taxes on those salaries, not on the premiums. The family's raise, instead of being 2%, would have been 1%, cut in half. And the family would have had $700 less to spend on everything else that are their priorities for the year. So that's the unhappy scenario, and thankfully, that's not what happened. Now in the next scenario, number two, what if we actually did better? What if we grew premiums at the rate of inflation in the state, and then we ended up at that blue dot in 2015 with lower premiums? If that happened, we would have spent $1 billion less as a state. The state would have collected $250 million more in income tax. The family's raise would have been 2.7% instead of 2%, and the family would have had, I think that's $500 more to spend over the course of the year on everything else they care about. So that's just one way to depict the importance of healthcare costs on the average family and on state outcomes that we care about. Okay, happy to take questions, and I'm sure Ray is too.
Well, thank you. This was, at both of you, this is, not only did you provide us with the background that we've seen before, but I particularly want to commend both of you for digging in deeper. So first, Ray, let me focus on the area that you focused on. We've discussed in many of our hearings about the readmission rate. And, you know, the fact that you've dug in much deeper and try to understand where those admission rates are coming from, behavioral health, the individuals that have 4 or more, is very important. So as we discuss, and I know we're going to discuss it throughout these hearings, the question is, well, what do we do about these populations? It's just not simply asking the individual hospitals to do more, and maybe they could, and maybe they should. But it's also, these are populations that do need, I'm sure you would agree, more intervention on the part of different components of our state. So I don't know whether in your looking at the data, there's even more that you can provide us with what we might be able to do to sort of lower those rates?
Sure, we just recently released a report that goes into the issue in more depth, and you make a very good point that it's, although obviously the hospitals have a major role to play and it's incumbent on them to play that role, you have to look at the populations as well that are driving it, because, you can't, I don't think you'll get to success if you're treating every patient as the same, situation. In terms of what the report teased out, other than the slides that I showed, I'm not sure, David, you might have been a more careful consumer of the report as a PhD than I am, so I'm I'm worrying about Chia's budget. David's probably reading our reports. No, not to put you on the spot, but so I don't know if we teased out other areas in the slides that I showed, but behavioral health comorbidities are obviously huge, and then the frequent hospital users seem to be another subpopulation that really stands out. But we'll make sure that everybody on the commission has a copy of the full report, though.
Great.
It has other
David,
insights.
Have you seen anything in that area?
I don't have too much to add beyond what Ray said at this point, but I think we'll have a good discussion of that when Karen comes up and we talk at that panel.
Beautiful. Okay, other comments or questions from my fellow?
Thank you both. This is amazing analysis, and especially the last few slides, David, where you help us see it from the point of view of an individual. I'd like to hear you riff on that just a little more. So specifically with respect to cost shifting to individuals, take us back the past 3, 4, 5 years. What's it been like? Have people been feeling more of this flow of money from their own pockets and out of pocket?
Yeah. I appreciated the Senate President's comment that 40% of our income growth is going to higher healthcare costs, and that sounds about right. I did an analysis, an article in Health Affairs a few years ago that showed pretty much the same thing across the country. I mean, as long as healthcare spending is going faster than income, then you're going to have that continue to happen. There is this trade-off, and there's an amount of compensation that employers are paying their employees, and as more goes to healthcare, less is going to income and salaries. And the question we're all asking is that worth it? Are we getting increased value in our healthcare for that excess money? And I think we together are identifying a number of ways where some of that care isn't high value, and that's really what we're all trying to do.
So there's a skin in the game theory here that the more people feel payment out of their own pockets, the more prudent consumption is, and the more favorable the effect on healthcare utilization patterns is. What's your view of that?
Yeah, that's a good question. I mean, for example, I think in the Mass Connector, I think that it's a little more. It's a well-functioning market in that people are presented with a number of choices in a nice comparison, and people are able to make those trade-offs of there are plans with lower premiums, and I might not be able to go to this provider or that provider, but they're able to save money and make that choice. For most people in the employer market, they don't really have that, and a lot of people aren't even really aware of this wage trade-off with healthcare premiums. It's opaque to them. So I would say for a lot of the employer market, that skin in the game doesn't really work. In terms of paying more out of pocket with the high deductibles, all the research shows that people cut back on both high value care and low value care, and it's a very blunt mechanism. So it's doesn't tend to achieve the goals of increasing the value for that dollar of healthcare spend that we hope for.
Wendy?
Thank you both very much. That was really a terrific presentation. I wanted to go back and just follow up on Dr. Altman's initial question. When the governor made his opening remarks, he talked about the critical importance of care coordination. And it seems to me for both of these populations that are driving the costs, behavioral health community and also the multiple comorbid. And I wanted to just ask Secretary Sudders if she would comment on the care coordination efforts that are tied to the Medicaid waiver that the governor spoke about, because we could all learn from that, and it doesn't just apply to the Mass Health population.
Thank you for that. So as part of the 17 ACO's core, so first of all, core to the belief of the waiver and the 17 ACOs that we're in partnership with is that if we manage care well, we will actually manage cost. And key to this is, in fact, care coordination, which is a core program of the ACOs, which is to really, I refer to as the Velcro touch, if you would, right? That is really attached to primary care of really coordinating people's care and much more active engagement with patients, particularly individuals who have high utilization of emergency departments and the rest. That really is core. We're rolling it out now, so I would say, March 1 of 2018 is going to be a very interesting as we roll this out together. So that's really it is key though, and it's, we have emphasized that this is not telephone contact, this is not light touch, that this is really, if I put on my social work hat, I keep saying it's a full employment act for social workers, not exclusively, right? But healthcare workers, peer specialists and the like, so there's not just one model to it. So I think it is to your, the opportunity to really do this differently.
I know you had a question too while you have
Yeah,
the mic.
so since I have it, it really is following up on Dr. Berwick's comment and David's, which is, if I put on my chair of the connector, which is last year when we went through a different shopping experience on the connector because of some changes in premiums, we did find that, in fact, consumers really did shop. They were less concerned about interrupting who their primary care was and really what was the cost and what was the cost impact on their family and what was the premiums and what were the deductibles, and that was the number reason why people actually switched plans was the cost factor.
That's right, and I've seen some of that data, and I hope that we have time to continue to analyze that a bit more, but I think specifically the situation with Neighborhood Health Plan, which had been previously somewhat subsidized, and then that ended and their premiums went up, and a number of people shifted away from that plan.
Well, in fairness to NHP and the other, the Commonwealth stopped doing premium smoothing.
Right, that's right.
Yes.
Thank you. That really was, those were great presentations. So just to follow up on that question that I was curious about, why connector care premiums rose at a less, at a lower rate.
Yeah.
Is it because people shifted to less expensive health plans, or did they seek care in less expensive settings? Or were they healthier? I mean, how do you explain that? And then also, what will happen to those plans or to those patients if the federal government stops the CSR payments?
I can answer part of that, and maybe I'll pass to Ray after that. In fact, they are not healthier. We did some analysis in our last year's cost trends report that was able to compare premiums across the markets in a controlling for risk in an apples-to-apples way, and it appeared that they were not healthier. In fact, they're a little bit higher risk, so even those differences in premiums are a bit understated. And as to why they're going down and why they are low, there's a number of reasons for that, and I can't parse it out specifically, and hopefully some other folks can speak to that. But these plans it's a highly competitive market. Plans compete to be that second lowest plan, the basis of the subsidy, and they tend to use more selective provider networks. Most of them don't cover a lot of the higher cost providers in the system, and that seems to be a big reason for why they're getting lower premiums. And why do they keep dropping? Again, people did shift to lower cost plans after the premium smoothing was ended, so that contributes to that as well.
But also,
Yeah.
unique to every other state in the United States, Massachusetts has a state rep in addition to the federal cost subsidies, the APTCs and the like. So we have a state rep in addition to the federal subsidies. So that does actually help
Right.
make Massachusetts, when you look at us compared to other states, keeps it lower.
Right. those premiums I showed were unsubsidized, but that does help. And I think that we're probably somewhat insulated from if the federal government stopped paying those cost-sharing subsidies, but I don't want to speak too much to that. No, not even.
Hey, I don't think
We
that
don't
way.
want that to happen. Okay.
Yes, sure.
I have a question either for David or Ray. In terms of, you showed a chart that showed that in terms of healthcare spending per capita, we're no longer the highest, although we're second highest. Do you know how we compare in terms of commercial premiums compared to the rest of the country? Where are we at the high end still?
Yeah, yes. I mean, if we're in the employer-sponsored premium market, yes, we're about the fifth highest, maybe 6, 7, 8% above the national average, and I have that data.
And has that changed over the last
The
few
gap
years?
has, going back 5 years, that gap was maybe 13, 14%, and now it's 6, 7, 8%. So it has shrunk, but we're still above the average. Yeah.
Yeah.
Great job, guys. Has the time come to look at the potential impact of showing the potential benefit of high deductible plans versus traditional HMOs and PPOs? Has any research been done on that, where people, when they're evaluating what plan to choose, even at the corporate level, where a lot of folks have access to a high deductible plan, the tendency is to move towards a traditional HMO and PPO? Have you found that data shows, based upon someone's health, or even if they have chronic conditions, where they still may be better served in a high deductible plan? Has any research been done on that?
That's a good question. One thing I can say, and I think Ray has this on a slide, is that there has been a shift in Massachusetts towards point of service plans, which is interesting. I think about 20% of the commercial market is in them now, so people are shifting away from I believe, both HMOs and PPOs into these plans. And I don't have a great sense of how they all compare. It's hard to get a good apples to apples comparisons of these types of plans. But you know, if you really had a nice comparison, my sense is that yes, HMOs are cheaper with more direction by the primary care provider, and you know, more of a role of referrals being managed. So I hope that helps to answer the question.
Yeah, I don't happen to have the kind of data off the top of my head, but I know we've looked at that issue of, you know, looking at relative price changes kind of based on insurance coverage. So we can get that to you if you'd like.
Thank you. Well, thank you. Before we break this panel, I just want to, Mike, this is your first meeting joining us, Secretary Heffernan, and so I look forward to the opportunity of working with you over many years. I don't know if you'd like to say something, and
I'll just say I'm taking lots of good notes on all the panels.
right. Well, maybe I'll take this opportunity to have my fellow commissioners introduce themselves. So for those of you who have not met them, so why don't you just start off? Right.
Thank you. Good morning, everyone. Tim Foley. I'm the labor representative here on the board from 1199 SCIU.
Good morning, Ron Mastrogiovanni. I'm responsible for running a firm that analyzes and projects healthcare costs.
Marty Cohen, the behavioral health representative on the commission, and I'm the president and CEO of the Metro West Health Foundation.
Mary Lou Sutter, Secretary of Health and Human Services. I used to occupy Marty Cohen's seat on the Health Policy Commission, and now I am in my ex officio capacity as secretary.
I'm Wendy Everett. I occupy the innovation seat and am the vice chair of the commission.
I'm David Cutler. I'm an economics professor, and I'm in the seat for a health economist.
Hi, I'm Rick Lord. I occupy the purchaser seat, and I'm the president and CEO of Associated Industries of Massachusetts.
I'm Dr. Carol Allen. I am a pediatrician. I practiced pediatrics for 37 years before retiring 6 years ago and doing other policy kinds of things. I did just get an MBA at Brandeis last spring, and I occupy the primary care physician seat.
I'm
Don Berwick. I'm a pediatrician. I'm senior fellow at the Institute for Healthcare Improvement. My field is healthcare quality, former administrator of Medicare and Medicaid, and I'm the consumer representative with the attorney, appointed by the Attorney General.
Good morning, David Seltz, Executive Director of the Health Policy Commission.
Good morning, everybody. I'm Lois Johnson. I'm the General Counsel of the Health Policy Commission.
And good morning. My name is Eric Gold. I'm the Chief of the Healthcare Division in the Attorney General's Office.
Very good. Well, I want to thank you both. Really a first-rate set of presentations, and we look forward to the report you indicated, Ray and David, continuing to work and dig into those areas that we talked about. So again, thank you guys very much.
Thank you.
Okay, I'm going to now turn the program over to David Cutler to introduce our next presenter. And with that, I'm going to ask stronger powers that be to sort of get this moved.
No, it's taped. The wires are taped.
Good morning, everyone. It's my pleasure to introduce our next speaker for the morning. We've been interested for some time in reducing medical spending, and the obvious issue that we have confronted many times over is the use of institutional care, both admissions and readmissions, at a higher rate than what we observe in other states. And so, as we've discussed this over time, it's tended to raise the blood pressure of most everyone on the commission as we've looked at this. So we thought the most natural thing to do in response to the tension produced is to bring in a cardiologist. So our next speaker is, in fact, a practicing cardiologist at Barnes Jewish Hospital in St. Louis, an assistant professor at Washington University, and also a health policy advisor for Barnes BJC Healthcare. Before that, she was a senior advisor in the Office of Health Policy at the Department of Health and Human Services, and before that, a professor at Harvard Medical School and the School of Public Health at Harvard University, which, if you work back the years, means that her undergraduate degree was completed at age 2, her medical degree at 4, and her internship was done at age 5. She's an expert in quality improvement, alternative payment systems and disparities. She's an associate editor at JAMA, a fellow of the American College of Cardiology, a fellow of the American Heart Association, on the National Quality Forum, and a few other things that I think I'll just leave out in the interest of actually getting to hear from her. So the topic for today is healthcare costs and readmissions, and we're hoping to learn both about obviously what makes Massachusetts unique, but also about the rest of the country and what trends we can learn about, and I'm sure we'll have plenty of questions for you. So Dr. Karen Joint-Maddox, thank you so much for being here.
Thank you very much for that kind introduction. I'm honored to speak to this group and look forward to not only getting to share some of the work that I and others have done, but also to hearing from you and hopefully spurring some discussion. So hopefully I can do the electronic part of this. Okay, so a quick just roadmap for what I'll try to cover in the next few minutes. First, talk a little bit about who is spending. I'll keep that pretty short since that was done just phenomenally by the prior speakers. And then talk a little bit about what CMS is doing about it, having spent the last few years in DC, though not speaking for them in any official capacity, we be very clear. Talk a little bit about what's happening on the federal scene in terms of health policy, and then maybe come up with some recommendations and some thought-provoking questions, hopefully, about how Massachusetts could think about ways to take some of the learning we have from these federal experiments and implement them here in a quite a bit more nimble circumstance. So national health expenditures, I don't need to show you this, they're high and rising, and you know where Massachusetts fits into both the overall and the per capita spend. And I'll just echo many prior speakers in saying that we know that healthcare costs remain concentrated. These are data from Medicare, a little less concentrated in Medicare because more, obviously, of Medicare is a spender. But you can see that about 10% of patients account for about half of the spending in Medicare, and even more importantly, about 3/4 of the potentially preventable spending. And that was from work we did categorizing potentially preventable spending as admissions for potentially preventable issues such as heart failure and pneumonia, things that could potentially be prevented, as well as preventable emergency department visits and all of the follow-up care that results from those, so any associated readmissions or post-acute care. And so you can see, as was said earlier, not only do costs concentrate, but costs around these really chronic, potentially preventable diseases do concentrate to an even greater degree. Now, who are these high-cost patients? Again, we're looking at Medicare. This is national data. And you can see that the high-cost patients are much more likely to be dually eligible, so in this case, Medicare and Medicaid, but primarily with Medicare as the primary payer, much more likely to have qualified for Medicare based on a disability, so generally the under 65 group, and as others have said, much more likely to have a mental health diagnosis, about 3 times more likely, in fact, on average to have a higher number of chronic conditions, and a real important emerging area of research, more likely to have 2 or more frailty indicators. And these are things like having a claim for protein-calorie malnutrition or a pressure ulcer or cognitive dysfunction, things that seem to have an outsized effect on functional status and on need for prolonged care and post-acute care beyond just a sort of a straightforward medical yes-no condition. So in terms of the national efforts to reduce healthcare spending, I sort of like to put them in 4 buckets. I'm not going to focus on all these today, but really just try to sort of pick off a few. Obviously, there's clinical innovation, and I know there's a lot of wonderful things going on in the state here in terms of innovating around the delivery of care. There's also, obviously, of course, all the innovation happening in pharma and in device companies and ways in which the care itself can actually change. I'm going to focus today on payment reform, which one might hope could spur some of that clinical innovation, but I'm going to focus on the payment side. And then I'll mostly stay away, at least from the Medicare standpoint, on things like price setting and consumerism, which obviously are extremely important across a number of these issues, but a little more than perhaps coverable in one session. So payment reform. Most of the country, and this is a different audience than most of the country is largely still in fee-for-service payment without value assessment. That's most episodic care, so most ER visits, certainly most specialty care visits are still largely paid in a fee-for-service manner without any value assessment on top of it. The first step in payment reform on the sort of federal scene has been fee-for-service payment with assessment of quality. And that's things like hospital value-based purchasing, hospital readmissions reduction program, or the physician value-based payment modifier, which is the precursor to all the payment reforms on the physician side coming down the pike. And all of those essentially take a fee-for-service algorithm. So you get paid, you charge for a chest x-ray, you get paid for a chest x-ray, but maybe you get $105 instead of $95 if you've done a good job in your quality up to that point on whatever metrics we choose. And that's essentially how the vast majority of the mandatory federal programs are set up. The next step is alternative payment models with a fee-for-service architecture, which is the, at least federal, most of the ACO models. Again, Massachusetts has been ahead of the curve here, but most of the Medicare Shared Savings Program participants are essentially still in fee-for-service medicine, but at the end of a year, their costs are reconciled against a cost target. And that's also the same for the Bundle Payments for Care Improvement Initiative, which was the voluntary version of the mandatory bundles that were just canceled, similarly relied entirely on a fee-for-service architecture from Medicare. And then finally, alternative payment models with a global payment architecture, which is much more what we see in Massachusetts, and really is probably the farthest ahead in primary care. We see very little of this pervading into the specialty market, and less so in real episodic care, where you can't imagine sort of having a global payment for an acute issue that might never recur. But certainly we see a lot of movement in this space in primary care innovation, both federally and locally. Also, of course, the fascinating case of the Maryland hospitals, which are on a global annual budget. But to my knowledge, that's the biggest such experiment on the hospital side. So to dig into a few of these for a moment and talk a little bit about what they look like and how they're playing out on the ground. So the Hospital Readmissions Reduction Program has been perhaps one of the more discussed value-based payment programs. It relies on evaluating hospitals on whether or not they have higher than expected readmission rates, and then assessing a penalty against all base DRG payments in a subsequent year based on your performance on those conditions. So this turns out to be real money. The penalties are capped at 3%, but right now they're running in the mid-ones on average. And this program has been democratized since its inception. As more conditions have been added, more hospitals have been penalized. And so now we see somewhere between 80 and 85% of hospitals penalized by this program, depending on how you count Maryland. Massachusetts is currently at 10th in the country, with 91% of hospitals receiving some penalty, a little below average on average penalty per hospital, but really most of the country looks pretty much like this, in the sort of the vast majority of hospitals penalized for at least a few conditions on excess readmissions. Now, has the program worked? Well, if we start by looking at this graph here, you can see the blue line on the top represents the target condition. So that was acute MI, CHF, and pneumonia at the beginning of the program's inception. And you can see a pretty obvious downward slope in the middle of that graph there that represents a significant drop in readmissions from a baseline. And remember, this is the Medicare population, so a baseline in the 21.5% range down to where we are now, more around 19. And that, at least to some degree, suggests that there was some efficacy on the national stage in terms of reducing readmissions related to this program. I do, however, think it's important to note two vertical bars that were in that figure there, which demonstrates the bulk of the improvement, if not, in fact, all of the improvement, happened between announcement and implementation. And that suggests one of two things. It suggests either that hospitals immediately got all of the low-hanging fruit out of the system and essentially made all the improvement they were going to make within about a year, or that once the magnitude of the penalties were revealed to hospitals, it became evident that a few extra admissions would more than make up that penalty, and maybe it was not worth the investment, perhaps beyond the hospital walls, that it might have taken to keep that going down. I don't have any insider knowledge on which of those it was, and I suspect it was a combination of both, but it is certainly salient to future program design. Hospital value-based purchasing doesn't even really have a decline to talk about. Hospital value-based purchasing is a much more diffuse program, so it measures hospitals on safety, mortality, patient experience, processes of care, and now efficiency. And if you look at any of the metrics in that program, there's very little evidence that hospital value-based purchasing has moved the needle. So here we're looking at mortality rates, arguably the most important thing we measure, though not the most weighty measures in the program. And you can see in the red dotted line are the participating hospitals, in the blue solid line are the non-participating hospitals, and there's a vertical line that demonstrates where the bonuses or penalties started. This is a zero-sum game program. And I think you'd be hard-pressed to find, and we did not statistically find, any evidence that there was a change in the trajectory of mortality improvement as a result of this program. But I think it's also worth considering that there are two sort of separate components to evaluating any policy. And the first is efficacy, and I've just shown you some slides on efficacy, or lack thereof, or partial efficacy. You think about that a little bit like the treatment effect in a clinical trial. I'm a cardiologist, I listen a lot to clinical trials, and I care whether or not a new antiplatelet drug reduces heart attacks. But I also care if it makes people bleed, particularly if they might die from said bleed. And I think in policy, we often don't rigorously evaluate those unintended consequences as part and parcel of the same program. And so I'd like to also bring up the importance of evaluating for unintended consequences in programs, not to say that programs shouldn't be done, but to say program design needs to take these things into account. And part of a complete policy evaluation is both the pros and the cons. So sort of like the safety effect in a clinical trial, what is safety in health policy? It's a little trickier to measure, and it's a little less clean, and it's a little more difficult to quantify over time. But it's things like risk aversion, or gaming, or penalizing vulnerable hospitals, or excluding vulnerable populations. So I'll talk a little bit about what evidence we have for some of the downsides of these federal programs. So first, I've told you about two of the hospital-based mandatory value-based payment programs, the Hospital Readmissions Reduction Program on the left, and the Hospital Value-Based Purchasing Program in the middle. And then I've added another one, the Hospital Acquired Conditions Reduction Program, which is a safety-focused program. And you can see that in all three of those, and this is work we did at ASPE, safety net hospitals, defined as those in the highest quintile of DISH index, are markedly more likely to be penalized by these programs and more likely to receive the maximum penalty. And particularly in the case of value-based purchasing, as I mentioned, this is a zero-sum game program. Dollars are literally taken from some hospitals and given to others, and you can see how that redistribution would happen based on these programs. Now, is that a surprise? Not particularly. And we know, everyone in this room knows, that social risk is related to health outcomes. And for example, if you look at the data that underlie the hospital readmissions reduction program, you can see in the middle column there, individuals who are duly enrolled in Medicare and Medicaid, so not a perfect marker of poverty, but a useful one, have between 24 and 67% higher odds of readmission after a hospitalization. Even when we control for all of their medical comorbidities that we can measure, we still see that their readmission rates or their odds of readmission are 10 to 31% higher. And that's meaningful. Now, whether or not we could explain some of that by functional status, or whether it's really all about social risk itself, a lack of support at home, no safe place to go at home to receive follow-up IV antibiotics, whatever it is, it matters. And so seeing those things play out in these hospital programs, I think is unsurprising, though important to document. So let's look at a different sector. Here we're looking at Medicare Advantage. And Medicare Advantage, as you all know, is essentially the program by which Medicare beneficiaries can get their health coverage through a private plan. Here they're broken up by contract. And it's about nearly a third of Medicare beneficiaries. So this is a big deal as well. And you can see here, if we break contracts that provide Medicare Advantage services into quintiles by the proportion of duly enrolled individuals they cover, and then we look at the likelihood that those contracts can meet the quality measures required to get the 4-star payment bonus. So if you get 4 stars as a Medicare contract, you receive an additional 5% payment bonus. You also have some other non-financial bonuses in terms of recruitment and marketing. So it's very important financially and not financially. And we see here that on the left side of the slide, while about 60% of the contracts with the fewest duals are able to achieve that quality measure, only 13% of those with the highest proportion of duals are able to do so. Now, I will show you some data that underlie these as well. Again, it won't be a surprise. And I will say, this is the pattern of performance by measure for duly enrolled individuals in Medicare Advantage. Duly enrolled individuals do worse on, starting from the top, blood sugar control, breast cancer screening, high-risk medications, flu shots. It is a pervasive issue. Some of this is almost certainly due to plan quality. There are some plans that have figured out how to make sure everybody gets a flu shot. Some of this is almost certainly due to the entire patient side of the equation, and that's access to care, it's access to safe places to exercise, it's health literacy and the ability to understand how to take medications, it's self-management. And so certainly this is not to say that it is all can be explained by poverty, but it is all linked to poverty through one mechanism or another, and we see these patterns play out in many places. And finally, the newest kid on the block, physician-focused payment reform. Here we're looking at data from the first year of the physician value-based payment modifier, which was mandatory. This is the first year of payment was 2015. And if you look at the orange bars on the bottom there, you can see all the way on the left about 20% of low-risk practices, meaning practices that did not enroll, that did not serve a high proportion of high social or medical risk patients. About 20% of them received a penalty in the first year. If you look across the remainder of the bars, about a third of those practices in the highest group of medical risk and over half of those in the highest group of social risk received penalties in the first year of this program. And this is only practices of 100 or more providers who one would anticipate anyways would be among the most able to initially sort of compete in this type of a program. Now, in this program, performance-based bonuses were optional in the first year. Some very brave souls signed up anyhow. And so you can see that the small, I guess it's a medium blue band, in the middle there are the performance-based penalties, and those are also much more common in the high medical and social risk groups. So again, since it was optional, we don't see big numbers there. We simulated what it would look like if they had all been subject to penalties, and those practices are much, much more likely to receive performance-based penalties as well. And once again, this is not a surprise if you think about the underlying data. Here we're looking at cost data, so the physician value-based payment modifier and MIPS, which will follow it, statutorily include cost measures. And in this case, it's total per capita costs of care attributed to a clinician. So if you're a primary care physician taking care of a patient, this is that patient's spend over the entire year, regardless of whether or not you had anything to do with it. But it's attributed to the practice to which the patient is attributed. And you can see both overall and for cohorts of diabetes, coronary artery disease, chronic obstructive pulmonary disease, and heart failure, dually enrolled individuals are markedly more expensive than their non-dual counterparts. Even when you risk adjust, those differences narrow a little bit, but are still in the multiple thousands of dollars. So where are we with federal payment reform? I think we could probably say it's been suboptimally effective, particularly given I won't even estimate how many dollars have gone into the stand-up, startup, and running of these massive programs. I think we would have liked to see a bigger move on quality and outcomes and costs based on that investment. And I think there's a high likelihood of unintended consequences, though many of them have been very poorly defined. I showed you the best we've been able to do in coming up with the impact, and it doesn't drill down nearly as well as we need on how those things actually play out on the ground. So the question then is, what can we learn? And as we think about program design, how can we sort of take what the federal government has done, or other state experiments for that matter, and maybe come up with some at least talking points around where we might think we should have some debate. So I'll present 3 strategies to improve efficacy and 3 to reduce unintended consequences. These are 3 of, I'm sure, many, and you will probably come up with better ones, but I will start the conversation. So to improve efficacy, I think one important point is matching the program design to the program goals. Do you want a narrow program or do you want a broad program? If you want to reduce readmissions, having a program that tells all the hospitals in the country that we need to reduce readmissions, simply announcing the program seems to be a fairly effective way to move readmissions, right? As opposed to value-based purchasing, where we've had processes and safety and mortality and a whole bunch of things in there, and the sort of laser focus on an issue has not been, I think, as biting. Data from some experiments in the UK suggest that gains do erode over time. If you measure one thing, people tend to focus on that thing. If you move away from it, you then lose some focus. And so perhaps rotating in high impact measures makes more sense than putting them all on the table at one time, for example. Do we use penalties or bonuses? We know that people are risk averse. Penalties mean a lot to people. And putting penalties on the table for standard of care, to me as a clinician, feels fair. If you're a hospital and you can't ensure that a patient coming in with a heart attack receives appropriate care, you probably deserve some sort of penalty. If we really want to spur innovation and the kind of integration and new thinking, and to really harness clinicians' drive to do good and do well, I'm not sure that penalties is actually quite the right behavioral economics to do that. And I'm not an economist or a behavioral economist, but I am a clinician. And feeling that, sort of harnessing that intent to do what many of us went into this profession to do across the spectrum of medical providers, I think there's probably something there. I think we need to ensure adequate incentives, although it is, as yet, I think, largely unclear what that means. And then focus on addressing the actual problems. And I'll give a couple examples of these last 2. So we did a survey after the hospital readmissions reduction program, in which we asked chief medical officers, or equivalent at about 1,000 hospitals, how they responded to different policy efforts to reduce readmissions. And you can see on the left of the slide that about a quarter-ish of hospital leaders responded that public reporting of discharge planning, so public reporting of a process of care known to reduce readmissions, led to their hospital having, from a leadership standpoint, a significant or great impact. If you look to the middle of the slide, you see public reporting of readmission rates. So now we're moving to reporting the actual outcome. And we get up to about 40% of leaders saying that really spurred them to try to do something different. And then you see on the right of the slide, once there was money on the table, about 2/3 responded that it had a great impact on what they chose to do in the hospital. And that didn't differ much. The 3 colored bars are by whether or not in the initial phase of the program they received no penalty, a low penalty, or a high penalty. So whether or not they had good, bad, or in between readmission rates at baseline, the behavioral response was similar. Another thing we learned from that study was that our programs are spurring us to focus on actions that don't necessarily line up with the problems for which we need solutions. So I apologize, the print is very small, but on the left column in the blue bars are essentially the top 5 strategies that hospitals were using. So they reported doing things like calling patients after discharge, scheduling follow-up appointments, using electronic tools, hiring a discharge coordinator. These are all really fundamental things that hospitals need to do to reduce readmissions. Those same leaders, when we asked them what were the biggest barriers to reducing readmissions, said lack of transportation, lack of staffing, lack of financial resources, and then the two top needs were patient mental health or substance use issues and a lack of mental health and substance abuse services. None of the strategies matched up with the barriers. And it seems like perhaps some of these programs have spurred people to understand what the barriers are, but we fundamentally have to shift the conversation outside the hospital walls if we're ever going to make a difference, if you see that the barriers have nothing to do with what the hospitals have started doing to try to reduce readmissions. So just to finish up, some strategies to potentially reduce unintended consequences, so the flip side of the coin. And I'll suggest 3 again and give an example of each. So the first would be accounting for social and medical risk and performance evaluation where appropriate. It is not always appropriate. Patients should get treated for their heart attack no matter how poor they are. And we should not be changing our quality standards for places where we know that hospitals or providers can control the outcomes. That said, there are many things that we measure that are very much influenced by the context in which people live and work and care for their families. And if we don't take that into consideration, we're going to see the patterns that I showed just spread. The second consideration is to reward improvement, which helps baseline poor performers enter and succeed in programs that may otherwise be inaccessible to them. And then finally, considering targeted bonuses, essentially rewards that are only available to clinicians serving vulnerable populations to get at both the access and impact of some of these programs. So I'll go through each. This is sort of a busy slide, but I wanted to include my favorite Massachusetts example from recently, which is that Mass Health has done some wonderful work thinking about how to account for both medical and social risk in costs. So this is published by Arlene Ash and her team. And I'll just go through the top line there. You know, the way that we pay plans essentially to provide care for patients is sort of predicated on the fact that they will be able to cover that patient's costs by what we pay them and use their efficiencies to make some margin and improve patient outcomes. And if we paid, so the average cost in Mass Health from the year that the data they used was $6,000. If you took the average individual with serious mental illness who is in Mass Health, their costs on average were $17,000. Asking a plan to provide care for someone who's going to have $17,000 of medical spending and giving them $6,000 to do it is a very good way to keep people from wanting to take care of our neediest patients, and also leaves them no ability to innovate. If you just adjust for medical risk, you sort of move to the middle arrow there, you see that a lot of that risk is accounted for by more severe medical illness. Not all of it, but we get closer at $15,600 instead of $17,000. And if you add social risk, you get pretty close, probably workable. If you look at the bottom row, which is individuals they categorize as being a Department of Mental Health client, which is indicative of a certain higher level of mental health needs, their costs on average were $30,000 in a year. Paying a plan $6,000 for that individual, again, is not a very effective way to make sure that they get the types of services that they need. If you adjust for medical risk, you get to about $17,000. If you adjust for social risk, you get to $30,000. Now, of course, there are losers in this. If you were running a model to allocate costs, people who do not have social risk end up getting a little bit less. So there's no easy way to reallocate here, but this is, I think, a very nice concrete example of why social risk really matters when we think about costs of care. Now to the point about improvement. So accountable care cost targets are inherently an improvement measure, at least as currently operationalized in the Medicare Shared Savings Program. So this is actually supposed to change in coming years, but for the first few years of the program, ACOs were given cost targets that was based on their own historical spending plus cost growth. So if you started as a high spender, your targets were high. If you started as a low spender, your targets were low. Many of the low spenders argued that was not fair, and I certainly see that point. But the interesting side effect, if you will, of having a program in which improvement is the metric of performance, you see here on the slide. On the right of that slide are the ACOs with the highest proportion of duals and disabled individuals, and they were the most likely to save in the Medicare Shared Savings Program. And not only to save, but also to share in savings under that program, suggesting that This improvement sort of methodology may be one way to recognize that you have inherently different levels of risk that you can't risk adjust away, but you can certainly make sure everybody gets better. And then finally, targeted bonuses. This is actually something that exists in Medicare right now. The physician value-based payment modifier has a piece of it where if you qualify for a bonus and you are in a particularly high-risk group, you can double your bonus, which sounds like a good deal, right? It's recognizing that people who serve populations for whom it may be more difficult to meet those targets, you should be extra bonus for your effort. And I think there is definite merit to that consideration. The problem here was that the groups at the high medical risk had a 0% rate of achieving a performance-based bonus. So there was no payout of the double bonus because there was no payout of a single bonus. So if patient factors are powerful enough, simply offering an additional bonus for performance at the same targets may not be a realistic way to really move the needle. So in summary, healthcare spending is high and rising and concentrated in complex and vulnerable patients. Payment reform has potential. I don't think any of us would be having these conversations if we didn't believe in its potential and believe in the way that it can really shape where people focus their efforts. Efficacy thus far, at least at the federal level, I think we could call modest. And payment reform must be done with caution or it could hurt the most vulnerable. There is a safety signal in all of these things, and the better attention we pay to it, the less likely we'll have unintended consequences down the road. So that's it, and I thank you very much for having me here.
Well, that was really fantastic. Thank you so much. So let me see if I, first of all, what you articulated and the information you presented, first of all, it couldn't have been done in a better way. I mean, you were just fantastic. But let me ask you this question. I mean, there's been a lot of controversy between people that believe that these kinds of, whether they're bonuses or penalties, should be much better adjusted for the complexity of the patients. And there's been this really pushback on the part of the federal government not to do it in the beginning. Where are we exactly? Are they beginning to recognize better the information that you're presenting? Or are we, as you pointed out, we're still not there?
No, we're not. And I think it's been a very interesting set of conversations. So when I was at ASPE, I worked on the report to Congress on this issue. And I learned a lot about government and the time it took to talk to everyone within the government on their thoughts on that. And I will say that there was not a lot of consensus. There are strong feelings on both sides. And one interesting side effect of not reaching consensus quickly in the federal side was that Congress went ahead and legislated. So they passed in 21st Century Cures, there's a provision for stratifying the hospital readmissions reduction program by proportion dual. I think you could argue about whether or not stratification actually makes the most sense. Stratification, if you're not stratifying by a very clean cutoff, stratum, I suppose, can set up some very odd win-loss along very narrow cut points and really does set different targets and different strata. As opposed to adjusting for the patient-only connected risk, which would be sort of a smaller bump. But the Congress felt it was appropriate to move forward with that. CMS did not think it was appropriate to move forward with anything absent that, and we ended up in this scenario where CMS is saying we don't want to adjust, and Congress is saying, but you must. And right now, CMS is working on how to operationalize that congressional mandate.
So tell me, before I turn it over to way you articulated it, my sense has been CMS is the one that's been really dragging their feet more than the Congress on this issue. And I'm sorry, I just don't get it. Explain, since you were there. You don't have to defend it. I just want to even understand it.
I will admit to many sleepless nights thinking through this while working on this project. There was not consensus. My personal opinion is that we need to adjust. It's unrealistic. It's like when you look at schools and you think that we're going to tell the teachers who have first graders who have never been read to at home and come in on the first day of first grade not having been to kindergarten that they're going to be penalized because their kids don't do well in a first grade set of scores. And take the money from wherever town that was and send it to Wellesley. that does not pass face validity to me. And that's essentially what we're saying we can measure well enough to do in the hospital industry. And I don't think we can. And I think until we have better risk adjustment, not only around social risk, but also around functional status, around frailty, around need, that we're using a really blunt measurements to say that we can measure performance when we're capturing some performance and a lot of noise.
Thank you so much. All right. I'll turn it over to, yes, Joel.
Great presentation, Dr. Maddox. Thank you. And I appreciate the spotlight on high social risk and as you point out, the need for alignment with financial incentives to address high social risk. But sort of short of that, are there other ways or that we can think about also addressing high social risk in healthcare systems, short of payment incentives?
Yes. So I think even changing the conversation around integration of behavioral health makes a big difference when it comes to social risk. The behavioral health community is light years ahead of most of the medical community in thinking about the patient as a whole. Especially as a specialist, I'm used to getting one little problem to sort of address and then sort of toss someone back to the primary care world. And that's really a failing in both directions. We need to bring behavioral health into primary care and get people linked back in that way. And we also need to link specialists in because we can do all the primary care payment reform we want, but if no one ever talks about PCI and spine surgery and valve surgery and all the really high cost things that we're doing, we're not gonna move the needle. That's not really a social risk issue. It's more of a cost issue. But I guess I would say behavioral health integration strikes me as the most concrete way to not only address some of the underpinnings of social risk and consequences of social risk, but also connect better to community resources.
David?
So thank you. I'm not sure my blood pressure is all the way at normal. It's come down some. I wonder if I could ask you to just give us some guidance for a minute. So let's say that our goal over the next 3 to 5 years is to really address the issue of unnecessary readmissions, hospitalizations, and so on. What sorts of things ought we to do in the next few years that you say, look, if you as a state really do this, the odds of success are high and the odds of unintended adverse outcomes are low. And if you don't do this, well, it doesn't really matter what else you do. You can pontificate all you want, but it's not going to be so successful. Like so sort of help us out with what things do we have to think about?
So I think the behavioral health issue just needs to be on the table. It's a big part of many readmissions. But just saying behavioral health and saying primary care without making them easily accessible to people in a way that they can use the care, I think is probably the other biggest logistic barrier. So I would see patients admitted to the hospital all the time who would come in with heart failure, and they would be 40 pounds heavier than they were when they left the hospital. Nobody gains 40 pounds of fluid in 2 weeks in a way that is healthy. And I would say, this happened 3 weeks ago. I've taken care of you now 4 times this year. Why does this keep happening? What's going on? And they would say, well, I started feeling bad, but I didn't really know who to call, and I wasn't really sure what to do, and I didn't really want to come back to the hospital again. And there's so much of this chronic disease is about helping people manage and understand and control in a way that doesn't require them to come in and be medicalized. So they avoid coming in and being medicalized until they have to come in and be medicalized. And then we're hospitalizing them for a week or 2 weeks in an ICU because they have 40 pounds of fluid on board that didn't start yesterday. And so I think rethinking the way that we manage chronic disease fundamentally, and if that's for patients that want to do it or can do it, if it's telehealth, if it's urgent care, if it's home visits, if it's something to demedicalize the management of chronic disease, I think we would gain a lot back in earlier detection and diagnosis that we're not going to get just out of sort of saying complete a discharge checklist. I think it's much more fundamental than that around how we manage chronic disease. I don't know exactly how to implement that, but I will say if you don't get out of our sort of medical model of making people come to the ER when they are critically ill, we are never going to push that back. Because once you're in the ER critically ill, you're getting hospitalized. So that's not where the intervention has to happen.
Question, comments, questions? Don?
Karen, this is just fabulous. Can I have your slides? First question. Suppose we wanted to engage in policy that made sure that resources got where the populations really were most stressed. You use the percent dual eligibles as a surrogate. I guess my first question: how good is that? If we just wanted the policy in Commonwealth said, if you're taking care of a stressed population, we want to get you resources. Should we use that? And if you wanted to enhance it a little more with 2 or 3 other variables, how would you know a place that really needed help taking care of stressed populations?
So it's a great question. So I think people have looked at this in one of 2 ways, and they probably both have merit. So one would be more individual-based identifiers, not only dual, but also disability. If you have diagnoses, places where there's a lot of mental health or substance abuse needs, those obviously help you define a population that is needy in a very specific way. When we look at the federal data, we can't tell apart spend-down Medicaid who have a reasonable asset base and the younger folks who have not only current poverty, but sort of an entire lifetime of poverty and all the things that come with that. Another thing that has a lot of promise but is a little harder to operationalize is obviously looking at area-based measures. So some countries actually do area-based targeting of resources using indices, of which we have very similar ones here, and that could be operationalized. Part of the trick is that those things tend to work reasonably well in rural areas and much less well in urban areas, because if you go, we used in the ASPE report, we used ZICTAs, and you end up mixing very, very wealthy urban areas with very, very poor urban areas, and you're not really able to slice and dice in the way that you'd need to really target. So I would say probably a combination of recognizing both dual but also disability and behavioral health, and then some overlay of area indices if you can get small enough to make that meaningful.
So have we got now in the United States or for Massachusetts use an index, an aggregated index that we really should rely on?
Yeah, so the Area Deprivation Index is probably the best developed, and it was just recently updated. Amy Kind is the researcher at Wisconsin who's done a lot of this work recently, and they've just updated it with the most recent census data. And they have it all the way down to census block, tract, I can't remember. And that's really where it needs to be used, is at the smallest blip you can get it to. And all the action is really in the tail. It doesn't matter too much where you are in most of the deprivation index. It matters really where you are in that sort of most deprived group. So if you can get the granularity to use something like that, and it uses all the, it uses education, income, housing. It really is a good aggregate. And so that would be the one I think is best off the shelf.
Carol?
Thank you very much for that presentation. So I'm not quite sure how to formulate this into a question, but as a pediatrician, I focus more on prevention. And I noticed that you talked a lot about individuals, especially those who are high cost, but not so much about intergenerational issues and family supports and community supports, and I'm curious if you have thoughts about how we as a society could intervene at a broader level so that we also protect children who are going to be the people with these high-cost conditions if we don't do something for them and their families, and address poverty and those sorts of issues, housing, things like that.
No, it's a terrific question, and I was certainly remiss in not bringing up prevention in 2 ways. Prevention in the how do we break the poverty cycle and sort of intervene in a social services sense to prevent people from facing some of those struggles that lifelong are incredibly predictive of poor health and poor health outcomes. And also, how do we implement prevention more broadly so that everyone moves towards sort of a healthier space? And I think both of those are really important. Part of the problem, and maybe why I didn't think of them either off the top of my head for this, was that the reward is so much longer. The reward is so much farther away. And it's often seemed to me like the populations for whom we have the best chance of making the economic argument for return on investment are the people who are currently on Mass Health or people who are on Medicare and Medicaid who are going to be publicly insured for many, many years. But most populations, that's not the case. And so I think it requires looking beyond a financial incentive to an insurance company and thinking, as you said, much more about community context and public health kind of interventions for that.
Although I would say 40% of people on Mass Health are children, and 20 something percent of people who are poor are children also, so.
Yeah, absolutely.
Shouldn't lose sight of that.
Any other questions or comments? Well, this was absolutely wonderful, Dr. Maddox. Thank you so much. But I have one final, maybe it's a question, but also a comment related to our data people, both Ray and David, that talked about. Can we make adjustments in the readmissions in Massachusetts for the kinds of variables that Dr. Maddox talked about? So that we get a better feeling for where we should be pointing our fingers. We're going to have a panel come up here to talk about how we do a better job. But as David Cutler mentions all the time, we want to focus our attention on areas that really can make a difference. So I'm just wondering whether we can marry up the kind of research you've been doing with the kind of data that we do have.
We'll certainly look into it. You know.
Glad to.
Karen, we'd love for you to help us, Garrett.
Absolutely.
That's great. Thank you so much. So you've been a very patient audience, and we've been a very patient commission. So we're going to take a 10-minute break, and I mean 10 minutes. And we'll then bring the next panel up. So please come back in 10 minutes.
Wasn't she great?
that you want us to
Yep.
trial. I mean, we're all in, you know, I think that, because I'm a nurse, it's the right thing to do. You know, if we can
That
do
was
it
a
and
great
be
thought.
successful,
What do you do about
it's good. So, you want us to independent. We
Yep.
don't want to, how you doing? You know, place like us to go as a partner. You can have an offline discussion.
I did.
Way to go. I was just trying to say what
But
we can do.
when you look at
Like the things that they're doing even as a medium-sized
spending increases,
be nimble and commit the resources, and there's so many layers there. I mean, we get discouraged.
Yeah. Yep.
You know, I wish every once in a while you might recognize that, but others would say, like, what can you do to help customers like that, like Sturdy and South actually trying, you know,
Make it
formed-
happen. Yeah.
Yeah, we won this Mass Value Alliance, and, you know, we're trying hard to together be a large collaborative.
Oh, cool.
So we can
Yeah.
reduce costs
All right,
on one
nice to see
end.
Mary. Okay.
And, because none of us really want.
Hey, Amy, how are you?
Right.
Nice to see you.
We have
Yeah.
5 systems.
Yeah, good.
They can't help it.
Oh, you have it this
That's
first
the
one?
design,
Yeah.
you know, I think
Yeah.
with that. So from my perspective,
Yeah.
you know, we can get support and
Yeah,
we
good.
can have more independent hospitals that are loosely forming like coalitions to stay out of having to come here and say, this is, you know, I'm out of money,
Right.
I have to merge.
Right, right.
You know, and I don't think anyone else wants to do that. And I don't think you guys want us to
No.
either.
Yeah. Well, worth a longer conversation, but I completely agree.
Definitely. Yeah,
So.
definitely. So I will make sure I do this. Thank you for
Thank
having
you.
me.
Yeah, of course.
Yes. Yes, I understand that. When you have great results like this, you can't lie. How are you? Sorry, Cheryl. We're going to swear you. Okay? They're all over the place.
Yes.
Yes, they are. Pushed it off.
We're back at the table today.
Oh, okay.
2-week hiatus. But it's, yeah, they're causing havoc.
I thought everything was
Actually, I'm glad you're on the end because I'm sure I would fall off.
Well, if I'm out of line, just.
Yeah, I was going to say, if you start pitching, I'll grab you.
No, I try to find an employee member who actively is involved with premium assistance in some way
I've been CEO for 3 years, a little over 3 years, and I was there for 2 years before that as a manager, and then I was on the board before that. And I've been a patient since 1980.
I live in Conway. So are you part of the VAC?
We are part of VAC. Yep. We did.
I work a lot with, obviously.
Yep. And what's your role there?
I am the nurse practitioner.
that is such a good thing. Yeah.
Initiative that is to work on the area.
Yeah. Hey, Brian.
How are your providers doing?
They're very well.
All
Yeah,
right,
yeah.
nice
I mean,
to see
it's been it's an interesting time as we get more and more nurse practitioners and sort of figuring out how do we run teams with one doc and two
Hey, nice to meet you. Nice,
the most effective.
nice to put a face with the
efficiencies.
name.
Who is a nurse practitioner? Done these before?
Yeah, a couple years ago. I did one.
You're a pro. And it's great because the nurses love it because they have a nurse who's in charge, and I think he also has a background in thinking really analytically. I suppose. And we're actually
That's why
looking at
David refers to it as the Super Bowl.
and then we're opening in Amherst.
Oh, really?
All right, if we could ask people to sit back down, we're going to keep going here.
Figuring out how we transition from just serving a rural population. I just feel like I want to get those homogenous to downtown
I have to like come here and sit and wait.
Diverse population, we think. I mean, maybe that we're just going to get people coming from Belchertown and where.
Yeah, so it was like you could, I had my phone in.
The idea
I
was
wasn't go before I'm on.
extremely diverse. Right in the bank centers? Right downtown? The town is leasing us their lower level. Good. I mean, the town asked us to come in, you know, this is not something we said. We need a community health center. Excited about so we need one more full-time nurse practitioner supervisor. For all of us. Dental and medical.
Worked out great. I got to do the motion and you got the second.
That's
great?
To coordinate behavior.
Right along.
So touch and go for
a few weeks there.
Hey, David,
I pride myself in not piggybacking.
I love them.
All the questions that were asked.
I'm with you.
That's
right.
Just always was, he came to my hospital when he was doing chapter 224 and talked with us. And they have different leaders for different times. I think he's the right one for now.
We are desperately outgunned on
You made that point really well. I
was happy to
actually
hear
did
that she said
your presentation.
Previous speaker said the transportation.
Set it up nicely. He's exactly what we need
It's
to
enormous. We have no public transportation.
And I heard from my people that went to that meeting, they're really behind.
All right. If I could get everyone to please take their seats, thank you.
That's a very good point. You should ask that. Excellent point. I never thought of that.
All right, as we begin this next panel, which is entitled Reducing Unnecessary Hospital Use, just to tee up this panel, wanted to share just a very few number of data points with the commissioners and with the public and with our panel here. This first slide is a summary of pre-file testimony questions that we asked 40 different providers and health plans. And we asked them to identify the top 2 strategies that they are targeting for healthcare cost containment. And here we have the answers broken down by both healthcare providers and health plans, and the percentage of respondents who had identified this particular area as one of their top 2 priorities for reducing healthcare costs. And what you can see is that reducing unnecessary hospital utilization was the #1 identified strategy by our healthcare providers. Second to that was shifting patient care from high-cost settings and increasing the use of alternative payment methodologies. On our health plan side, their #1 targeted cost containment strategy was reducing the growth in prescription drug spending. But second to that, again, was reducing unnecessary hospital utilization. So you can see that this is a shared priority of both providers and health plans in Massachusetts. Secondly, a few by the numbers, many of which have been already presented here this morning. Our readmissions, all-payer, all-cause readmissions rate is 15.8%, an increase from previous years. The readmissions rates for patients with a behavioral health diagnosis is higher. And here at the bottom of the slide, we've presented the risk-adjusted readmissions rates for some of the panelists who are joining us here today. Emerson at 14.9, below that statewide average. Bay State Franklin, which is right at that statewide average. And Tufts Medical Center with a risk-adjusted readmissions rates of 17.4. Would also note that we have calculated that reducing readmissions by 20% would yield almost $250 million in annual savings to our healthcare budget, and would highlight that many of the programs in our community hospital investment program, known as CHART, have been working on reducing readmissions. So with that, I'll turn it over to my chair, who are going to just key up the panel here. So thank you very much.
Thank you, David. So what I'd like our panelists to introduce themselves, but do it in a way, keep it short and, focus. We're going to try to leave as much time for comments and questions. So we don't need to go into detail about your organization, but just briefly introduce yourselves so everyone knows who you are. So.
Good morning, Commissioners. My name is Christopher Gorton. I'm the president of Tufts Health Public Plans, which is the division of Tufts Health Plan that serves the Medicaid, Qualified Health Plan, and under 65 dual populations.
Good morning, thank you. My name is Eliza Lake. I'm the CEO of Hilltown Community Health Center, which is a rural, federally qualified community health center that serves Western Hampshire and Hamden counties.
Good morning. My name is Cheryl Pascucci. I'm a family nurse practitioner, and I work at Bay State Franklin Hospital out in Greenfield, Massachusetts. It's considered a non-for-profit, high public payer hospital, and I work as part of the CHART investment program, where CHART stands for Community Hospital Acceleration, Revitalization, and Transformation Program.
Good morning, I'm Chris Schuster, the president and CEO at Emerson Hospital. I've been a CEO for the last 20 years in a community hospital, a DISH hospital, and a critical access hospital, so really in 3 different locations. We are one of the recipients of the CHART grant and have made it our life's work for the last 2 years around reducing readmissions.
I'm Mike Wagner. I'm the president and CEO of Tufts Medical Center. I'm an internist and primary care physician. I have the experience of not only working at Tufts Medical Center on and off for the last 27 years, but I've worked as a inpatient internist at 3 of our community hospitals, Holy Family, Melrose Wakefield, and Lawrence Memorial Hospital. So I have a pretty good understanding of healthcare delivery, both in the academic and community setting. And Tufts is a focused academic medical center that provides high complexity care for some of the sickest patients in Massachusetts. So thank you for inviting me to be here.
Okay, let me start off and flip the discussion from what we talked about last time. I like to believe that all of us, or at least most of us, are very conscious of the fact that treating very complex, difficult patients that have serious mental problems and a number of other problems does indirectly lead to maybe more hospitalization, more difficult. But I want to flip it around and saying, while that is a legitimate, and I wouldn't say it's an excuse, it can't be the justification for not doing anything. If quite the opposite, if you know who those patients are, the question is, what can we do? What are you doing? And what can we, from the Commonwealth point of view, do to help you do what you're on the front line. You see what needs to be done. So the question is, what can we do collectively and, but using your own experience in terms of what seems to work, in terms of getting patients to the right level of care. So.
And if I could just add one additional sentence to that. In talking about how you've made some progress, if you'd give us some estimate of how much progress you've made. So if you're now at 15.9%, did you start out at 20%? Kind of what's the quantitative value of the progress you've made in addition to how you've made it?
Who would like to start? All right, you're smiling, you get the mic.
So Bay State Franklin decided to participate in the Health Policy Commission's CHART program with the aim of decreasing ED revisit rate by 25% for folks with behavioral health, primary or secondary, and inpatient high utilizers by 25% for 30-day revisits as well, readmissions as well. And we were allowed to use innovation to figure out how to make this, this work. And we used the triple aim and decided that the most important thing was to determine what emergencies kept happening with these folks that kept making them come into the emergency room. And the second thing was what mattered most to these folks. So what the team decided to do was to hire community health workers, 3 of them, and they're employed by our community partners. 2 of them are full-time with LifePath is our local regional ASAP, and 1 is through community service, community support options, which is our contracted crisis, and they offer respite as well as IOP and have outpatient behavioral health services, and we have a peer on our team. As well as myself, I'm the nurse practitioner, we have an LICSW, and we have a therapist on our team. So the whole goal is to engage with individuals as soon as humanly possible, wherever they are. So if they're in the ED, we meet them in the ED. If they're inpatient in the SNF, or ideally at home as soon as possible after discharge. And it's not about typically their medical reason for why they show up in the hospital. When we ask the question, what emergencies keep happening, it's typically around their social determinants and their behavioral health needs. Most of our chart participants are Mass Health recipients or dually eligible for Mass Health and Medicare. And they need things like housing. So homelessness is a huge part of our program. Do they have access to food? Do they have access to transportation? Do they have any money coming in? And we have poor transportation in Franklin County, public transportation. So actually getting to where they need to go to fill out the application or to access that service is missing. So the community health workers actually pick them up in the emergency room and drive them to wherever they need to go. We have secure texting in Franklin County, so we're able to communicate with our community health workers in real time when they show up. So all of it is about immediacy and flexibility. And the folks on our team who have the most flexibility are these community health workers and our peer specialists who will also pick them up in the ED and take them directly to detox or to an AE meeting or to engage in an outpatient service.
Anybody else want to jump in, and then we'll...
So over the last 4 to 5 years, when I was the chief medical officer at the medical center, and then Saul Weingart, who's the current chief medical officer, I would say that the readmission work has been one of the most important projects we've worked on. And I have to look at it from several segments of populations that we care for. One is that we are located in the inner city. And so there is a subset of patients who come to the emergency room on a frequent basis, and they are the cause, unfortunately, of a fair number of admissions and readmissions. And so we've worked in collaboration with organizations in and around Tufts, and also Boston Medical Center being a mile away, organizations that focus on the homeless, looking at our high ED utilizers, and we've collaborated between our primary care practice, the ED, and the social agencies in the community for looking for ways that we can identify what are the triggers for coming to the ED and things that we can do to support those services to reduce ED utilization. On the primary care side, we've implemented programs in which we have a better coordination between the discharge process in the hospital and working with the primary care practice that then do a warm handoff and then providing for identifying patients who are highly likely to come back and ensuring that they have the right information and are also scheduling appointments, tests, and other work that needs to be done, to create a more seamless handoff in terms of care coordination. The other area is around our complex care, which is actually a much broader group of patients, and they fall into several product lines. And one of them is in our advanced heart failure program, where we care for a lot of heart transplant programs for patients who are awaiting heart transplants. They do end up being readmitted quite frequently because they have intractable heart failure. We have a multidisciplinary team that's comprised of nurses, nurse practitioners, social work, physicians that work in collaboration to manage that population. But that we do, since we do take care of a subset of patients in cancer, heart failure, neurosciences that are more likely to be readmitted on a regular basis, and it is one of the areas that we spend a lot of time on. The metrics and the data that we look at with regard to readmission, we mentioned before we started, the Mass Hospital Association has done some work in looking at readmission rates and looking at social determinant issues to see whether that narrows the spread of readmission rates. And I think it would be worthwhile to get the data from the MHA in terms of the work that they've done. We look at the University Health System Consortium data, which is academic medical centers around the country, and the statistic we focus on is unplanned readmissions within 30 days. Unfortunately, academic medical centers, by and large, have higher readmission rates for some of the reasons that have been talked about, having to do with dually eligible, poorer populations and populations that have many more behavioral health issues. So we look at that statistic, and over the years, we've seen that number progressively come down, and now we're in the 50th percentile.
Other questions of my,
Did you?
Well, go ahead.
yeah, good.
So from the health plan perspective, we have a different lens because we're provider agnostic. So, and one of the things that we see is the readmissions are not always to the same facility. The recurrent ED visits are not always to the same facility. And so we're looking at the populations, and I want to be careful to emphasize that we have multiple populations, and trying to stratify within those populations who are the individuals at this point in time who are having difficulty, who seem not to have their needs met. And then we try and put together care management programs, care coordination programs that the Secretary talked about a little while ago, to address those people's needs. And there are a lot of people who you can help with fairly generic care management programs that we've been doing since the 80s. But then there are people in these subpopulations who have very particular needs. And I would just point out a couple of programs we've put in place over the course of the last couple years, just to underscore what you can do, right? So it's, my point being, it's not an intractable problem. You just have to figure out what the tool is to address the issue. So for high-risk pregnancies, we found that we were having some difficulty, particularly with people with all the social determinant issues that are being talked about, limited English proficiency. We're having trouble with them coming into the hospital a lot with complications of their pregnancies, bouncing back into the hospitals, the babies bouncing back into the hospitals. And so what we put in place last year was a high-risk doula program offering the same services you can get in clinic-based settings and in facility-based settings. But the doulas are paraprofessionals. They're not licensed clinicians. They often speak the same languages that the people they serve speak, and they've been specially trained to help expecting mothers manage a high-risk pregnancy. And then they follow up with them for lactation counseling and other things, again, all done in the member's home. What we found for the high-risk people who have been served by this program is about a 27% improvement in compliance with postpartum care, a 10% improvement rate in terms of C-section rates. And while I can't attribute a specific drop to readmission rates because it's a fairly unwieldy measure, we're reasonably confident that with better postpartum care and with lower C-section rates, we're seeing improvement there. Similarly, we've begun to address the needs of families who have kids who end up in the NICU. That turns out to be a fairly special care management situation, and we've been able to, by using consulting neonatologists, get to a place where we're substantially reducing the number of readmissions of discharged NICU babies and of returns to the emergency room for the various things that kids return to the emergency room for. So I think in sum, I would say that you need to have a foundation to do care management that cuts across the delivery system and extends out into the community. And then you need to be able to innovate in terms of what Dr. Maddox said, solving specific problems with solutions that are designed to address them.
So if I could ask one question, I like the idea of kind of the population health-based approach. If you were to take your example of high-risk pregnancies, how do you then communicate back to the provider so that we're not having silos of innovation or silos of interventions within the system, but we start to have an integrated system that's attacking this problem?
So when we set up this program, there was an education component with the providers who would be impacted. And in fact, most of the referrals come from the providers. The doulas attend the provider visits with the moms. And are sometimes in the hospital at the time of delivery. They're certainly around. And so the idea is, in fact, to do precisely that, is to not create yet another fragment or shard of care, but to be able to tie things together. The doulas have been very helpful with some of the moms who often come, the refugees who come from cultures that are non-Western cultures, may be resistant to interact with their providers. They don't ask questions, they just say yes. And so the doulas have been very helpful, in fact, as sort of being cultural ambassadors to help bridge the gap between the members and the providers.
David?
So let's say that it was thought to be an extremely important issue for either your institution or your health plan to address the issue of readmissions. Like this was sort of a number one. What would your institution be doing? You know, let's say, so 3 years from now, we want this issue to be really substantially different than it is now. What would your institution have to do over the next 3 years to make that happen?
So we spent the last 2 years, thanks to our CHART grant, working with the team to put together a program that's been in place for 2 years, and we started out somewhere in the 23%, and we're now down to 14.9% readmissions. And so we made an investment on the part of the hospital as well as through the CHART, and our funding goes away this year. And because of the results we saw, and because it's the right thing to do for patients, everything that we implemented, our board made sure that we had in the budget. And so in order for us to continue, if we stopped now, we know that our rates would creep back up. So I do think there needs to be some sort of investment in hospitals and letting this happen. We know that it's not going to pay off until 10 or 15 years down the line. It dovetails with our strategy to use IBM Watson for population health management. But we've recognized that now we can't just be in our own silos as hospitals. We have to reach out to the community. We have to coordinate care both within the hospital, outside of the hospital, and the teams that we've put in place do just that. And they also reach back to the primary care physician so that, you know, it's integrated across the system and everyone knows what the plan is and how to support that patient, whether they're a behavioral health patient or whether they're someone with a targeted diagnosis that we selected. I think patient identification is really where you have to start, and then you have to have the algorithm for how, with each one of these, you're going to tackle them. Some people need more behavioral health support, others will need more medical support, and it's things as simple as, do they have a scale in their home so that it's not 40 pounds before they present to the ED, it's 5. Not to the ED, but to their team, so they avoid going to the ED. So it can be done. I think the support needs to be put in place with the successes you've seen through the CHART work to be able to support hospitals, community health centers, and so forth to be able to do these types of things.
No, I'm sorry. Okay, I'm sorry, David. Oh, no, just Eliza wanted to say.
Okay, sure.
So I'm speaking from a different perspective as a primary care provider, and I just want to introduce my organization. We are a community health center, and like most community health centers, we provide medical, dental, behavioral health, optometry. And then in the hill towns in Western Hampshire and Hampden counties, we are the only provider of any of those services in our 600 square mile service area. There is not a single other doctor's office or dentist or anything. And so we also provide most of the social services in the area. We have all of the health insurance navigators, domestic violence victim advocates, the family center, social service workers. There is no one else in our area that provides those. So we are sort of the one-stop shop in our area. The problem is that everyone has to go down the hill, literally, to get to a hospital. And so we have 5 different hospitals that our patients go to that can be as distant as 60 miles from each other. And so I would say that the thing that would be most helpful, there's a lot of things, but there is no public transportation anywhere in our service area. And again, we use community health workers to provide some of that transportation, which is, when the distances are so huge, incredibly inefficient. And there is no ongoing support for community health workers. They have always been grant funded. And so they come, our volume of community health workers is very unstable. I think communication with the hospitals, setting up systems so that our providers know when someone has had an admission, particularly for behavioral health issues, is critical. Access to behavioral health, we have social workers on site, but getting psychiatry for our patients is There are enormous wait lists, and often if we refer someone to a psychiatrist, then we lose them as a behavioral health patient, so we lose them, we lose that continuity of care. And then the last thing is that our community health workers and our social service workers do everything they can to make sure people have access to public benefits, but there isn't housing. And particularly for people, I know that our domestic violence victim advocates, people have to leave the community. There are, besides VNA and some ASAP home care services, there's no long-term supports and services. And so people leave the community, and that can obviously have impact on the health of that group.
Well, we should look into those. Ron, you want to?
Do you think a segment of the high-risk population would benefit from the use of technology, whether it be wearable devices, texting services, or things of that nature? And would it be cost-effective?
I can just say quickly that if we had internet, that would help. There are vast, the majority of our towns do not have high-speed internet. We, as an anchor institution of the community, have gotten fiber at our facility, but and even cell coverage, my cell phone works at one of our sites and not at all at one of another one. So that's a challenge.
We have a grant from Blue Cross Blue Shield that we've implemented over the last 2 years where for certain chronic diseases, congestive heart failure, chronic obstructive pulmonary disease, and some behavioral health issues like depression, we use iPad technology. And so our case managers save a visit every time by checking in regularly with the patients. There is also some texting, need to speak with you, that sort of thing, which acts as triggers. So I do believe that the technology can be used to check in with folks and then assess whether they need a different level of care. We then implemented some urgent care centers in our area so that patients could, without access to primary care because they were so busy, they could get in to see someone and just get checked without having to go to the emergency room, which is what they would have done under normal circumstances.
Don?
First, thank you for this work. It's moving to listen to you talk about your commitment. I have two questions, if I can not dominate too much. One is, I'm having the thought as I listen to you that we have to be a little cautious about focusing on readmissions or even ER revisits as if it were a primary outcome, something that we really want to achieve. The thought is, to put it boldly, that's not what we want to achieve. They're an indicator of underlying circumstances that affect the well-being of the community. And I'd welcome some comment on that. And then if I can slip in a second one, which is only vaguely related. Should we contain costs? I mean, all of you are dealing with pretty vulnerable populations, it sounds like. You saw the figures on Massachusetts #2 in the country, $8,800 per person. I have my own opinions about how much we have to spend, but I'd like to know yours. Should we aim for 15% of GSP or 4% down or 6% up? How much waste are you seeing, even though you're dealing with vulnerable populations?
So I'll start on are all readmissions a bad readmission? I'll kind of start with that. Or should we be focusing solely on readmission? And I think your point's an important one, which is that being a internist and taking care of a lot of patients at the end of their life and having discharged a lot of patients from the hospital, there is that agonizing moment of doubt when you're finishing the discharge paperwork and wondering and knowing that the person that you're discharging is going to have a rocky course over the next 6 months to 6 years, depending on how their disease course falls out, that when you're doing all of the paperwork and the education, you still have a lingering doubt whether that person's going to end up being readmitted or need to come back or when they will need to come back. Because invariably with almost all disease courses, especially near the end of life or when someone has a catastrophic illness, coming back to the hospital and being readmitted is just a reality of the care that we provide on a regular basis. The issue is are there readmissions that are avoidable that we can be focused on by having better systems in place? And the answer is absolutely yes. I think to the question on if there's something we could do that would dramatically help in incenting practices or incenting the healthcare system to focus on this. On being a primary care doctor, I believe a lot of this is around the work we're doing in patient-centered medical homes, team-based healthcare in the practices, better communication between events that occur in the hospital or events that are like discharges or being seen in the emergency room, to activate resources within primary care practices. In many other markets, primary care physicians in some of our practices that are very attuned to population health and risk, they take a very proactive approach in identifying patients who have had an event like an unforeseen emergency room visit, or getting sensitive information back from home care providers that may be early indicators of a person's decline, and will take a proactive approach in getting back out to the patient, either in the home or into the office, to readjust medications or to adjust the care plan to try to avoid a hospitalization. I think the real focus is around primary care practices, supporting primary care practices, and making sure that we have the right resources to build robust team-based healthcare in an environment in which primary care has become more difficult, has become more stressful, and with the opioid epidemic is probably also associated with higher degrees of burnout and difficulty. So it'd be great. That's where I think the focus has got to be, but I think the challenges are great in that area. And then in terms of cost, there are causes of cost variation that occur in this state. Being at Tufts, it would be remiss of me not to talk about, wait for it, price variation that occurs in the marketplace. You know that is going to be a topic that I'm going to put out there, but it is a real issue. Price variations that occur in this marketplace probably account for $500 million of excessive spend for the state, the residents, the employers, and I think it's an area that needs to be addressed broadly as a state policy issue.
Does anybody else want to? Yes.
At Emerson, we work with our 3 big primary care groups, and so reducing utilization in the hospital and the emergency department is just part of our overall population health management plan. And so, as Dr. Wagner said, it's really putting the resources in the primary care group and having everyone in the community talk to each other. One point that hasn't been brought out, I agree with all the points that Dr. Wagner had around the team, is getting palliative and hospice care into the discussion earlier. One of the initiatives we've had with Healthcare Dimensions, which is a palliative care hospice organization, is training our primary care physicians and our hospitalists so that we can begin to have those discussions earlier. And I do think a lot of these things now are investments, and I think 5, 8, 10 years, we'll see the investment will pay off in terms of the work that we're doing. But it is really a change in how we approach and tackle patient care. And so while I think there's an upfront investment, I do think in the long run, the total medical expense will go down.
Dr. Gordon?
I think also it's important. One of the weaknesses of the readmission metric is that it focuses on a single level of care, and often what drives the readmission is a failure of the post-acute care or what comes after that. And so, working on transition of care, particularly for people with behavioral health challenges, can be critical. So we've seen that we sort of made an internal promise to ourselves. We don't do discharge to homeless if we can avoid it. And if that means for paying for administrative days in order to keep somebody in a safe, warm place while we find an appropriate source of aftercare, then we think that's a good admission, that's a good investment, and we try and do that. So I think that that's one of the issues, right? If what we're thinking about is throughput, so that people come into the emergency room, they get into the acute care, and then they have to go somewhere post-acute. And I don't know that we've focused as much on post-acute care. I don't know that we have good metrics for post-acute care. And I think that is, that's a critical component. With respect to your second question, I run a Medicaid plan. Yeah, we ought to spend less money, right? We're trying to be good stewards of the taxpayers' money. The good people in Massachusetts want their less fortunate neighbors to have coverage and access to high-quality health care. We have to do it in a cost-effective way. There is waste in the system. There are ways by focusing on some of these other things like the social determinants to eliminate some of that waste. And it is absolutely work that we should continue to do.
Thank you, all of you. I was very intrigued to hear about the use of community health workers, the doula home visiting and program, the high-risk pregnancy program. Also, a little discouraged that the community health workers are funded through grants and not some other more sustainable mechanism. And it seems to me that these are relatively low-cost, high-efficacy interventions. And one of the difficulties I wrestle with, or I think we wrestle with as a Commonwealth, is that we have a matrix system. So we have many different providers and many different insurers. And so, you know, how do we make sure that this is a community-based intervention that services everybody in the community, not just a Tufts patient or a Medicaid patient, or, you know, but it's coordinated in some way so that if you're a primary care physician taking care of your patient in a community, you don't have to figure out, oh, I want a community health worker to go to this patient because they have these needs, and I have to figure out which health plan and how, you know, so how do we as a Commonwealth, as a state, really invest in these things? And I think that gets a little bit to Don's question about spending, where should the spending be? You know, can we move it more to an investment and in some of these areas, as well as housing? I heard three things come up: housing, transportation, and infrastructure, like, you know, internet and cell phone. And how do we move that conversation so that we put the resources where they ought to be and everybody has access to them?
So had I answered the previous question, I would say some of the similar things I'm going to say now, which is Hilltown is one of the 15 health centers who have created an ACO called Community Care Cooperative C3. Yes, right. And one of the things that has been so appealing to us as one of the smallest health centers in the state is that we have not in the past had the capacity to develop the systems to, you know, respond to, you know, these issues. And so by having those DSRIP dollars coming directly to us, we can look at practice transformation and in, you know, to the previous question, avoid hospitalization at the beginning, not just the readmissions. And so using data, having a larger organization that has data analytics that can help us identify who are the people who are likely to be hospitalized in the first place, and have our community health workers, have our behavioral health workers go out and our nurses go out and do outreach to those folks to stop them from developing the conditions in the first place. So I think it is, I don't know if it would be a reduction in cost, but it is moving it into those areas where we can prevent the more expensive care from happening.
Can I follow up on Carol's question? I'm sorry, I was just very intrigued by Carol's question. Is there anyone for whom there is a positive business case for making these investments and reducing admissions, readmissions, or is it always a negative economic case?
So we do this all the time. It's part of what the health plans do. And so I have a small army of these people. The challenge has sometimes been interacting with the providers. So you were talking about siloing. And one of the great advantages we see in the ACO transformation that's happening in Mass Health is now for the first time we're sitting down and having constructive conversations about exactly these sorts of things. And when I say to Health System X, you know, I have people who will go and knock on doors. I can arrange for transportation. We can make referrals for housing and those sorts of things. And so that just opens up a whole bunch of possibilities. So I would say I'd love to take sole credit, but I think the Medicaid health plans across the board all invest in these things, and we would love to see people make more use of them. The payment methodologies which are being introduced under the ACO transformation will in fact free up money to enable us to pay for it. And what you would see if I could give you access to the DSRIP plans of the organizations that we're working with is these are fundamentally the challenges that we're trying to answer.
Yeah, just to go ahead.
Just briefly, where we are at risk contracting, there's a financial incentive for us to be reducing hospital utilization. In fact, the more aggressive the group is, the subgroup within and understanding that they can have a role in reducing unnecessary hospitalizations or readmissions, they're at aligned incentives to do so.
I just wanted to say thank you for reorienting me a little bit around whether or not we need to focus on readmissions. There just happens to be a population of people who happen to be high utilizers. It can be for a gazillion different reasons, and we address it all the same way. But everyone's different. The thing about the triple aim is that we're trying to change the experience of care for a population that the system is failing them. And to change the experience of care, we've decided that to make this care as person-centered as possible is the way that we're going to address every single situation. So what matters to them and what do they need? And the fact that our population is the one that we talk about every week, and we have interdisciplinary team meetings, and whoever is involved with this individual gets to tell us, gets to drive what we do next. And one of the community health workers said that we didn't develop this model, it was the patient population that developed this model, and I think that is just spot on. Sometimes I'm the person who calls 911. I mean, sometimes, you know, that's where the care is. But that doesn't mean that when you lighten their load or lighten their stressors, whether it's a behavioral health problem or a social determinant problem, or it's really about connection. And initially the connection is with us, but ultimately primary care is the most important player in this. And to have a robust primary care practice where people get all of their needs met is a fantasy right now. That's what it feels like anyway. In Franklin County, primary care providers' panel sizes are 26% larger than the state average. And they're not driving out there to work with us. So when they connect with us, the natural progression would be to connect them to the next logical place, which is their primary care provider and the other folks on their team, or the behavioral health specialist. And sometimes that means that because they didn't have transportation and maybe they've lost their primary care provider or lost their behavioral health provider because they've missed too many visits because of transportation typically, we have to smooth that over. Sometimes I go with them to their primary care visit, especially if they're very complicated or end of life, or I go with them to their specialist so we can sort of talk it through and make some decisions. But really, it's about connection. My fear is that this grant's coming to an end. We are not recipients of the Medicaid ACO in Franklin County, so we thought this would be a natural progression. And one of the unexpected, I can't remember what Dr. Maddox called it, but you know, unanticipated downsides of a program is that what happens to all these people that have really strong connections. We are not a 30-day program. We have folks in our program for 18 months. That we're simply texting with to check in. You know, initially, yes, we do a lot of work for them, filling out applications and doing PT1s and doing all these things. And then we do it with them and we drive to places and we work together on problems. And then ultimately, we're cheering them on. We're just, you know, how you doing, checking in and making sure that they know they have a contact. So when then it starts to escalate again, then you can nip it in the bud.
I think Chris has.
No, you don't exactly see the payoff initially. So if you were to do a dollar to dollar, we've invested a lot more outside of the grant. But if we've had to step back with our primary care groups and say, for our community, we've committed to population health management. We know, and we have metrics that we look at as our baseline, and over every year we see that they're improving, some slowly, some a little bit more quickly. So we hope to see the benefit 10 years out. So if you, in terms of improving the overall health status of our community. So we've invested in other things like a health and wellness center that has over 100 different programs that bring people in to talk about prevention. Why do you need to have these tests done, prostate screenings, you know, mammographies, and so forth, with the hope of trying to put this whole system together in our community of educating them. And then for people with chronic diseases, there's support groups for them. For teenagers, there's things about depression. We've had a lot of that in our community. And how to deal with anxiety, stress management. We brought the Benson Henry Center in from Mass General to do provider training around stress reduction. So in and of itself, you could almost look at it as a cost. We choose to look at it as an investment. It would be great if the system funded, recognized, and supported it, because I do think for the whole system, it would pay off down the road. It would be very hard for us to shut it off right now, as my colleague was saying, because we've made so much progress, and I do think we would take a step back if we didn't have some help. So if there's anything you can help us with, it's continuing to support the funding for things like this.
I'm going to kind of bring us back to how we can work to prevent avoidable hospitalizations, and it's a question for the whole panel, but I am going to pick up on your earlier point, Chris, which was really discouraging to me, that this could be a 10 to 15-year effort to really drive down the avoidable hospitalizations. And I know you also referenced improving the health of the community, and those two things go together. Did I misunderstand?
Yeah, I think we've seen in a 2-year period, we've had a 31% reduction in hospital admissions. So in a short period of time, with focused effort and teams, we've been able to do that. I was referencing improving the overall health status of a population takes 8 to 10 years to really see the impact of that. And that's really changing a whole cohort of patients in your community. We can get hospital readmissions down in a shorter period of time, and we've demonstrated that we can do that.
Great. So my question to the panel then is, let's say 5 years, 3 to 5 years. If we pick up on Dr. Wagner's point of being at risk is a little bit more of an incentive. For the entire panel, what changes would be most incentivizing? What changes in the payment system would most incentivize you to really put this issue at the top of your list and make a big effort to drive that rate down? If we went to global payments tomorrow, would this make a difference?
So the one thing about risk adjusting for a population is that you have to engage with them annually, right? And you're supposed to have a plan around how you're mitigating all those risks. So the risk around a particular individual in a population is very specific to them, and the more at risk that person is, the way is how I feel that we should be paying into this idea. The provider that is taking risks for this particular person, when you know them well, it's not just their medical condition, and you must know their medical condition well as specifically as possible, but you're also, how are you monitoring it? How are you evaluating it? How are you assessing it? How are you treating it? All of those things also should be occurring for things like their behavioral health diagnosis, as well as their social determinants of health. And then a real patient-centered medical home, person-centered medical home, would feel like one-stop shopping, where all of your needs are being met in one place. And that's when I think having a global payment for someone would actually feel like you're actually able to take care of everything that's going on.
Go ahead.
Dr. Wagner.
So if I can add another dimension to this, is around the interplay of reducing hospital utilization and where that utilization drop is coming from. So let me kind of point out what I think is a concern when I think about reducing hospital, and thinking about this panel and thinking about stuff we think about every day at Tufts in collaboration with our community partners, is emergingly there's a system, two systems of care that are emerging in Massachusetts. Those that are predominantly focused around commercial lives and those that are focused around the mass health lives. And there is a separation. There are hospitals that are doing a lot of mass health work that are in predominantly more economically disadvantaged cities and towns. As we move into more risk on the mass health side, the hospitals that have jumped into this with both feet are those hospitals that have large mass health populations. Why? Because there's access to the district dollars, and we all know that the current mass health structure is not sustainable for the long term. And to the credit of the secretary and to the governor and to the undersecretary and the work that's been done in creating a credible mass health ACO structure that we have faith and trust is the best option for us to make that leap, we've jumped into that, but not without a great degree of trepidation. When we look at the risk profile on the mass health side compared to the risk in Medicare and on the commercial side, the mass health program is a very risky program. But remember, the hospitals that are taking on this risk are disproportionately hospitals in economically disadvantaged communities. On top of which, coming back to my theme, these hospitals have also been relatively disadvantaged in their commercial payer negotiations and suffer from disproportionately low reimbursement compared to the systems that have gotten higher rates of reimbursement. The net effect of all of this is that we're entering into a period of time in which the community hospitals that serve very vulnerable populations are at the greatest risk. And if on top of it, they disproportionately are taking the hit with regard to hospitalizations, which is the bread and butter of what keeps them economically viable, then we will lose very valuable economic engines in poor areas. From this, the one other piece that I'll just put out there is that it is important for academic medical centers that partner with community hospitals, especially those in economically disadvantaged areas, to help ensure the repatriation of secondary and, in fact, even tertiary services to those hospitals so that they are important so they can be viable economically. I think that's a very important discussion that you should be having with other academic medical centers as they come. Our approach with our community hospital partners is not what can you do for us? In other words, how can you channel patients to us? It's how can we bring care back to the community and help you become important economic engines for your generally underserved areas.
I also think it's important not to forget about the most important healthcare secular trend that we're facing right now, which is the opioid epidemic. So it's driving substance use disorder and its various manifestations is driving huge numbers of readmissions. And going back to the point I made earlier, part of the issue there is you can detox somebody in a couple of days, although we give them 14 here in Massachusetts. But where do they go after that, right? So the vast majority of communities have no infrastructure to repatriate people after they've had an acute detox. And so if all they do is go back to the community where the problem manifested itself in the first place, they just use again and they're back in. So I think to the extent that we focus, as I think we've been doing increasingly over the last several years, on calling out the impact of behavioral health issues, particularly substance use disorder, and in building the infrastructure we need to take care of that, not simply inpatient beds, but all of the other things that we need to do. And I think the governor's administration in the recent waiver renewal really addressed filling in the gaps in terms of the substance use delivery system. And so I think those things, if we can get somebody into a bed, cleaned up, and then out into a pathway that will lead them back to reintegration in the community, that's critical, and it will have a meaningful impact on the costs that we're currently facing.
Tim, you want to jump in?
Well, I would just actually add to that one thing that we see, though, is that alcohol is still our number one substance use disorder. And people do not want to leave their job. Detox is not an option because if they leave, they lose their jobs. And then you're just exacerbating the other issues. And so that I think we have not seen as much of the opioid issue up where we are, but the alcohol is really crushing at the moment.
Thanks. Dr. Groton, I just wanted to ask a question for you. In the pre-filed testimony, you said that Tufts has implemented a readmissions penalty. I was wondering, one, how effective you've seen that in reducing rates of readmission, and two, how do you take into consideration all the factors that were presented in the presentation before around unintended consequences and some of the issues that you've addressed in this panel today around culturally competent care, access. So just wondering how you take that into consideration.
So unfortunately, I can't answer questions about the pre-filed testimony. So as we explained to the HPC staff, the pre-filed testimony is based on our commercial product. That's not a business that I run. And so we don't have a program like that in public plans.
Do you have time for another question? Yeah. In your testimony, a number of you mentioned non-healthcare sectors. Housing, Kit, you mentioned transport. Cheryl, you talked about. Can you comment on the degree of cooperation in the Commonwealth, both on the public sector side among agencies and on the private sector side among advocates around total community approaches to health and dealing especially with vulnerable populations? How good are we and what should be better?
So we learned a lot about our community partners when we looked at who the resources, what the resources were out there in the community. We started to meet with them routinely, particularly around CBFS with our folks that have persistent mental illness or under DMH. And so we meet with them monthly and go over, all of the issues. And what we find is even that care needs to be augmented. That the communication between social services, behavioral health services, medical services, that there's a lack, and mainly just because they don't. There's no system for it. So we've really become the mediator of that. When there's a particular individual who's struggling maybe in all three sectors, we bring three sectors together and with the individual if they will agree, but we always have their permission to sort of talk it through. And I would say that the stressor, the greatest stressor is really around DMH really feeling like they're at capacity. And I think they would love to help more and be more involved, but the capacity is the problem. Did I answer your question?
Yeah, Joe.
Eliza, I would be remiss if I didn't pick up on the fact that you're the only community health center testifying over these 2 days. And as the governor mentioned this morning, the Community Health Center Act wasn't reauthorized yet. We expect that it will, but could you talk about the immediate effects that will have on your work?
Well, if in fact it is not ever reauthorized, it is catastrophic. It is for my health center about a sixth of our budget, maybe a little more. I'm not doing the math really fast in my head. So we would. We rely upon that as part of our federal mandate to serve everyone who comes in our doors. And in Massachusetts, that's easier than in other states because of Health Safety Net. But still, we rely upon those funds to keep us going and to be able to do a lot of the work that community health centers are known for. I am hopeful, given a history of bipartisan support in Congress for community health centers, that they will rally through the distractions at the moment and get that reauthorized. For us personally, our federal grant luckily goes through May, and so we are sort of holding tight in this storm of uncertainty that surrounds all of us right now.
Forgive me for special pleading, but let me see if I got the essence of what was said by several of you. And I want to focus back on CHART. And several of you have pointed out how important CHART was to your organization, your institution, to focus on this. Now, it might look like special pleading because we've had the responsibility for administering CHART. But let's put us aside and talk about what I consider to be a win-win-win of the CHART-type mechanism and focused a bit on what Dr. Wagner said. The reason why, listening to you, and I hadn't even realized it myself, it's a triple win. First of all, the funds disproportionately went to activities which focused directly and indirectly on social determinants. And much as, well, I'm not saying I'd even would like, the likelihood that we are, as a country or us as a state, is going to be able to spend more money on top of everything we're spending on social determinants without redirecting it from the delivery system is very small. So we need to figure out a way to refocus money. And in a way, CHART does that. And it does it in a way, Dr. Wagner, which you emphasize, because it focuses on community hospitals and delivery systems. And it does it by taking money, quite frankly, away from the high-end payers. So while we don't directly get into the payment, indirectly, CHART really is a win-win-win if I'm hearing you right. Do I have that right?
You do.
I do.
We love
Anybody
working with the
disagree?
CHART people.
Pardon?
No, I mean, I'm just, and it doesn't have to come through us. A mechanism like that, which does take money away from the ones on the top, the ones who have the smaller needs, redirect it towards the ones that have the higher needs, and be redirected towards social determinant type activities. That's really what it's all about.
And it's the partnership that we've had, with David Seltz's team that has really allowed us to be innovative, and it's very collaborative, and that's really what you want to see if we're going to take care of people.
But Dr. Altman, I have to say, for the however many years now I've been on HPC since the beginning, this is actually, the Emerson example actually is one of the first times I actually have heard of the CHART, of a great example of how CHART was a bridge to your change. Because CHART was never intended to be a forever program. It was intended, it was meant to incubate change within systems that then you incorporated the change and institutionalized it, if you would, or, as opposed to another grant program that we fund, and at the end of the grant program, it goes away. So that you actually have made the change. Your board, as I heard you say, right, decided that the investment was worth the continuation by your system.
Luckily, we had built it into our budget, but that was the question when we presented the results to our board for our budget approval. Is this program in? Because this fits in with all the other strategic initiatives we have around managing the health of our population. We try to meet patients wherever they are in their personal health journey, and if we're going to do that with the community, then we have to have programs like this. So they insisted on, as did our medical staff.
I'm sympathetic to the idea of having programs end, I agree. But in this case, if we can figure out another way to do it that redirects funding from the acute care to the, that's really what I'm aiming at. Doesn't have to be CHART, it could be something else. And you're in a different, well, I don't know, I don't want to, you may be in a financial position where some of the other community hospitals are not, but you're not at the end of the day, so anyway, I don't disagree with the
We
secretary.
take care of places besides
But that's really
Concord,
what
for
I'm
sure.
aiming at. I'm trying to figure out a way to sort of get money out of, and ACOs is another example of how to do that. Because the reality is, as you pointed out, the likelihood that we're just going to add money on top of everything else we're spending is very unlikely, given, as the Senate President pointed out, how big a portion of the budget is already our mass health program and healthcare, as we pointed out, even for people who are employers. So the idea we're going to add money into the system is very unlikely. And not only that, not good. So, any other people want to, before we, if not, I really want to thank this panel. It was wonderful. Your presentations were right on. All right, well, so we're just right on time. We are going to break for lunch for 45 minutes, and we will be back. We have a lot going on this afternoon. We're going to be focusing on presentations from the auditor, from the Office of the Attorney General, and as well as a number of other.
Last time I was swimming before I dreamt about ACOs the entire night. I was like, God, this is not.
I feel like I told Norm, we were keeping an eye on what you're doing.